Muito boa tarde, bom dia e boa noite.
Good afternoon to everyone. We have people watching from all over the world, and this is one of the great advantages we have from doing remote events. It's not easy, we all know, but the attempt to do a hybrid event was thought to start going back to normal life or to the new normal life little by little. So today we have the honor and the privilege of hosting our 11th international workshop, Diagnostic Test with ensured quality that are accessible for public health problems. For us, it is even a greater privilege knowing that we have so many people supporting us in this long journey, and especially with the support of top organizations. So I would like to thank USAID, NC Wellcome Trust, the London School, Chatham House, everyone who have been supporting LEDIV in its initiatives. And of course, I also have to thank CBDL, the Brazilian Chamber for Laboratory Diagnosis, the International Diagnostic Center, the Inter-American Regulatory Convergence Alliance, and AudiMed, which is the Alliance for Medical Devices for Latin America, for all their support. So for this opening session, we will hear the initial remarks from Daniel Vasquez from USAID, from Jessica Rope from NC, Scott Kiosi from Chatham House, and Rosanna Pearley from the London School. So thank you all for being with us. All the presentations are being recorded and will be made available within our education programs and in the work we do to foster regulatory convergence. So now I'd like to invite Mr. Daniel Vasquez to make his initial remarks and talk about the work of USAID in the project for regulatory convergence of medical devices. Jessica will also talk about that. Thank you very much. And Daniel, the floor is yours.
Thank you so much. I appreciate that introduction. I'm Daniel Vasquez, Senior Standard Specialist with USAID. It's a pleasure to join you today. And just talk a little bit about the work that we are doing jointly with AdvaMed and the Inter-American Coalition under the COVID-19 Medical Device Regulatory Convergence Project, also known as MDRC. Just to give a little bit of background of how this project came to life. As the pandemic was hitting and the US government was programming its support to help partner countries address the challenges of the pandemic, we very quickly, jointly talking with our industry partners, realized that donating medical devices and other goods that were needed to help countries effectively address the pandemic was not enough. There was a group of rules and regulations that needed to be also adjusted in order to effectively address the challenges that we were facing and that were preventing some of the products that were arriving to the market to arrive at the points of care and patients. So with that in mind, we work with AdvaMed and the Inter-American Coalition in designing the MDRC project. And that has allowed us to reach out very effectively, partner governments around the world to work and address some of the lack of convergence challenges that we have been identifying. I look forward to listening to the conversation today. Unfortunately, I won't be able to stay for the whole of it, but I'm sure that you will have a very successful program, and I wish you the best of luck in the presentations and the event as a whole. Thank you very much.
These initiatives. Jessica, would you like to take the floor?
Thank you, Carlos, and thank you, Daniel, and welcome everyone to today's international workshop again on this quality assured and accessible diagnostic tests. As noted, my name is Jessica Roop, and I represent the American National Standards Institute, which is a private nonprofit organization that administers and coordinates the U.S. voluntary standards and conformity assessment systems in the U.S. And it's my pleasure to be here with you today. As Daniel alluded to and touched on a little bit as well, I'm going to provide a little bit of additional background regarding the Standards Alliance Phase 2 program, specifically related to the MDRC. And as we're all aware, since the start of COVID-19 pandemic, nations across the world have really raced to increase production and access to medical devices to prevent and treat the deadly virus. And in-demand resources, including the rapid diagnostic test kits and PPE and ventilators, include all of those in-demand resources. However, countries cannot safely deploy these products without a really strong medical device and regulatory convergence framework and knowledge of emergency use authorization procedures and rules. So the Standards Alliance Phase 2 is a public-private partnership with the U.S. Agency for International Development and ANSI, which among other priorities focuses on COVID-19 response and recovery. In particular, the SA2 COVID-19 MDRC, or Medical Device Regulatory Convergence Project, is focusing specifically on reducing barriers to countries' importation of US medical devices that aid in the fight against the COVID-19. MDRC is a partnership, again, between ANSI and USAID, and it's spearheaded specifically by the Advanced Medical Technology Association, or AdvaMed, and they are an ANSI member as well. So the MDRC serves to increase transparency and predictability of partner government countries' regulatory ecosystems for medical devices. It aims at aligning them with international standards and improving overall national quality infrastructure. So ultimately, the collaborative effort will enable the importation of the test kits, improve government's acceptance of these international standards for medical equipment, and diminish regulatory barriers and impediments. And lastly, train various agencies and private sector on documentation that is really required for regulatory approval and the proper use of medical device testing and equipment. So we are in our third year of implementation of this program, and we're making great progress. And the topics that you all be addressing today throughout this two-day workshop will contribute to the overall MDRC achievement of the various objectives. So in advance, I'd like to say thank you to you all for your support and your effort to make this event a success. And I'd like to thank you again for your attention. And I'll defer to Carlos and the moderator to continue the opening remarks for this valuable two-day session. And thank you so much.
Thanks a lot, Jessica. It's really a great pleasure to have you here and explaining a little bit of what we have been doing. This journey is not so short, it's a long journey, and we do have a lot still to accomplish. And to bring access as an easy thing, or access to new qualities that can change a person's life, is really essential. And for that, in the ADAP, which is the Acceleration Access to Diagnostic project, I would like to invite Scott Giossi from Wellcome Trust to give his initial speech. Scott?
Hello everyone. So yeah, my name is Scott. I work at the Global Health Program at Chatham House. So I'll be quite brief. I just wanted to thank everyone for attending this event on behalf of Chatham House. And Chatham House is the Global Health Program specifically, aims at trying to accelerate progress, facilitate, conversation, and also strengthen global health security. And we think that through the ADA project, we can try and achieve these goals. And yeah, we look forward to hearing from the attendees, and I hope that we achieve a fruitful discussion. And that also will, together with the workshop that we had in Cameroon a couple of days ago, and also with the one that will be held in Asia next year, that these conversations will help build on the global event that will happen in 2022, and also develop an impactful policy brief at the end of this project. And just a few words on the Cameroon event. It was also very fruitful. We had also simulations that allowed to have quite in-depth discussions. So we actually reached 10 key points to act on, and also looked at solutions for these barriers, and also looked at what are the next steps after this workshop. And I'm sure Rosanna will also tell you more about it, both at the ADAPT and the Cameroon event after me, I think, and during this event. And that's all from my side. Thank you all again.
Fantastic. Thanks a lot, Scott. And I would like now to bring the person behind all these connections. Actually, the one that is making this constellation of stars really show and shine and actually go to the same direction in order to promote access to those who need the most. Rosanna Peeling, would you take the floor, please?
Hello, Carlos. Thank you very much. And indeed, it's my pleasure to be here to welcome everyone to the 11th workshop that we have co-sponsored together with all our different partners in our mission to increase access and accelerate access to quality assured diagnostics. As we all know, the role of diagnostics has been constantly changing without changing global health security issues, global health priorities. Different diseases require different types of diagnostics and how they should be used in different settings. And so the COVID-19 for us had many teachable moments, and required now new thinking about how diagnostics should be done and should be used. And there were new technologies that had been developed during the pandemic. And so I just like to say that it would be impossible for us to do anything about the advance of diagnostics without all of you as partners in this long mission to increase and accelerate diagnostics for quality, to advance the quality to assure diagnostics to achieve good outcomes for all. And so with that, I'd like to bring you welcome from the London School and the International Diagnostic Center. And on behalf of Dr. David Heyman, who unfortunately had scheduled conflicts and could not be with us today, but he will join as soon as possible. Thank you.
Thank you, Rosanna. It's really a great opportunity for us to share experience, not only throughout Latin America, which is going to be most of the event, but with colleagues from other regions and other countries as well. Last week, it was held in this ADAPT program, another similar event in Cameroon. Rosanna is going to bring a little bit more details, but it's just to show that it's a global effort towards improving access. We have different needs, but that can be accomplished with the same products most of the times. So now we are going to start the seminars, and the first speech is going to be about introduction to the consultation of accelerating access to diagnostics, when Rosanna is going to show exactly a little bit of more detail on this program and how it's actually been working and what is the next step for us. Rosanna?
Thank you, Carlos.
20 minutes.
Okay, thank you, Carlos. What I'd like to do now is to do a short introduction to this consultation today. And I'll start with some slides on the need for new thinking about diagnostic access. And then in particular, in the second part, I will talk about this Wellcome Trust funded project to accelerate diagnostic access, ADAPT. Now, as we all know, for a long time, diagnostics are useful in patient diagnosis and management, so that the correct care could be given, the correct treatment could be given. It's also critical in surveillance and disease detection, at least for infectious diseases, that alerts us to when there are outbreaks and unusual happenings. And then testing allowed us to confirm what is the reason for the cause of the outbreak, and also the containment, and including contact tracing on other public health interventions that could be triggered from a positive or negative diagnostic result. And of course, it's useful for epidemiologic research and clinical trials for both drugs and diagnostics. Now, with the pandemic, we have now looked at how diagnostics could be used in non-healthcare sectors, such as in mass gatherings, in schools. So that's a new use of diagnostics. And how could we be optimizing the test characteristics for that remains to be seen. There's also a big global health crisis that have been worsened because of the pandemic, and that's the antimicrobial resistance global crisis. And so diagnostics has a critical role to play in the precision use of anti-infective drugs, because if we lose these drugs, then all of modern medicine cannot be the same as before. And perhaps we will go back to the pre-antibiotic era when even minor infections can kill a person. Now, first about the pandemic. We all know that pandemic or epidemics used to happen only periodically, maybe, a big epidemic once about every 10 years. But since the last flu pandemic in 2009, we've seen a continuous occurrence of outbreaks that are occurring with more frequency and more severity. And so we really need to strengthen our access to diagnostics in order to confirm clinical diagnosis, to screen for asymptomatic infections within communities, to try and interrupt the chain of transmission, and then to use diagnostics, especially antibody tests, to estimate the true extent of the outbreak, the geographic hotspots, and also monitor the effective interventions. Now, as I mentioned before, antimicrobial resistance is a program that has been really adversely affected by the pandemic and lockdowns. Now, in 2016, Lord Jim O'Neill issued a report to say that if we don't do anything about antimicrobial resistance, by the year 2050, 10 million people would die from resistant infections instead of the current 700,000. The cost in terms of global loss in productivity would amount to about $100 trillion US dollars, and 28 million more people would likely be pushed into poverty. And there we need to, again, try harder to look at the use of diagnostics to guide patient management and the appropriate use of antimicrobials, especially for syndromes like respiratory infections, for which a lot of them are caused by viruses and not by bacteria, but yet a lot of patients are prescribed antibiotics for these infections. Secondly, we need to be able to use diagnostics to screen for resistant bacteria, especially in health facilities, in order to prevent its spread throughout the institution to affect the vulnerable people. We had reports from countries that, in fact, a lot of COVID patients, when they go into hospital, because of the long stay, they acquire resistant infections, so that even when they got over COVID, they die from these resistant infections instead. So finally, we want diagnostics to conduct surveillance so that we know what are the trends and to be able to assess the impact of interventions. Now, how has the COVID pandemic affected AMR? A study that was conducted in 88 countries showed that there was a gross overuse of antibiotics for COVID patients. About 72% of hospitalized patients receive antibiotics when only about 8% demonstrated bacterial or fungal co-infection. There's been increase in healthcare-associated infections within hospitals because more people have been admitted to hospital, especially for long term. And then because of lockdowns, there's been major disruptions to health and vaccination services, and that increased the risk of infection and use of antimicrobials. Now, we all know now that we use diagnostics, we use tests as a diagnostic tool in the pandemic to confirm clinical diagnosis in symptomatic patients, to do contact tracing, and also to do case finding in hospitals and care homes and in first responders, so that they are not acquiring infections for those they care for, nor transmitting them to other people who are vulnerable. But we now also have diagnostics as a public health tool. We have tests to protect the vulnerable situations. Like if you go into hospital or care homes, you need to test negative in order not to spread infection in case you are one of the asymptomatic spreaders. We can use tests to release people from quarantine when they're in quarantine because they're positive or because of travel. And then finally, but not the least, is the test to enable the reopening of schools, workplaces, and mass gatherings and travel so that we could, the economy could recover. These tests use are also being supplemented by the fact that in some countries, home testing has been approved for use so that people can test themselves at home or with a healthy telehealth proctor. Now, when we use the test to enable, that's a new use of diagnostics. What are the required test performance characteristics? This is something that it's not something that regulators alone would know how to do that. In fact, it would require regulators and policymakers to come together to consider the test sensitivity and specificity that's needed. And don't forget that testing is only one of several layered interventions to reduce the risk of transmission in these events. There's also wearing a face mask, physical distancing, hand hygiene and cough etiquette, and also ventilation when it's an indoor event. Now, testing could have, the lack of appropriate testing could have major economic consequences. And I want to show you this example of what happened in Kenya. In May 2020, the government of Kenya decided that truck drivers are a high-risk group and that they must show a negative molecular test in order to leave port, to drive to different throughout the country, as well as to different countries in Africa with their goods. And because the results for molecular tests take up to 2 weeks to get back to the truck drivers, within a very short time, there was a 90-kilometer traffic jam at the port of Mombasa, where trucks were lined up with drivers waiting for their test results. All of the trade has been halted because of this. And because truck drivers are congregating there, there's also a risk of transmission amongst themselves during that location. It was a very desperate situation. And fortunately, in July, the International Organization for Migration provided more rapid PCR tests to the truck drivers across Kenya as part of an effort to reinvigorate the regional economies in South and Central and East and Central Africa. So they made the test results available within 24 to 36 hours, and they tested 17,000 people and from July to October. And you could see that, having the right test at the right time for the right patient group or people would really make an important contribution. And it's not only test sensitivity or specificity, but time to result is really important. Now, what are the lessons learned from this pandemic? There are new considerations that we need to think about. When we try to balance, I always say the 3 A's of accuracy, access, and affordability. Now we need to add the time to result as a one key component, depending on the circumstance of where testing is done. And so the risk of false positives and negatives that regulators regularly consider now should be, added by the risk of considering the lack of access, especially to marginalized populations, because they will continue the spread of infection if they don't have access. So we haven't got a handle on control of diseases, or if the test had a long turnaround time. So those are the new things that we need to think about in terms of risk. And then for incremental benefit, it's not only to the patients themselves, but to society as a whole, which means that with the consultations for policy, we need to be thinking about other partners in this consideration of diagnostic access. And then the second point is that throughout the pandemic, there's been a lot of technological innovation. This convergence of digitization, diagnostic technology, and information technology has allowed us to look at dashboards like this that I'm showing from the Johns Hopkins website. Daily, they post how many cases there are around the world, deaths, and now even vaccination by country as well as by region. And so we could see from firsthand that there's a real advantage to make better use of the convergence of these technologies to allow data to be turned into real-time intelligence in order to inform public health interventions and control strategies. Finally, policy development, as I mentioned before, needs to be more inclusive of other partners such as civil societies, departments of finance, education, trade, tourism, and in country and across countries. Now, we were very fortunate in 2019 and early 2020 to be funded by the Wellcome Trust in a project called Accelerating Diagnostic Access, ADAP. And that's because we long recognized that the pathway to from bench to bedside is actually fragmented with many duplications that are unnecessary, duplications of clinical performance studies. There are blocks and there are gaps along the pathway that really impede the development, evaluation, regulatory approval, policy development, and implementation of diagnostics that we need. And so the length and the current complexity of this pathway substantially increase the development costs, so that the final cost of goods is much higher than they need to be. And that in turn reduce the impact that the test could have on patient outcomes and disease control, including epidemic response and antimicrobial resistance. So you could see from this figure that regulatory approval including clinical performance studies can take as long as 3 to 5 years. And then policy development and adoption, including procurement distribution, could take 5 to 7 years. So we want to make sure that we have means of accelerating this pathway, but without compromising in quality. And one of the initiatives of WHO and other partners have been to use emergency use listing or authorization. And so countries can actually try to follow that process so that they don't have to duplicate a lot of the clinical performance studies. And I think we'll talk more about these later. So the objectives of this project are to conduct stakeholder mapping to better understand the regulatory licensing and development of policy pathways for point-of-care diagnostics within key countries in Africa, Asia, and Latin America. And we focus on point-of-care tests because they are tests that can be done at the point of care or point of need, and therefore are more accessible by their nature to begin with. So that's a good starting point. Second objective is we like to increase awareness amongst all the stakeholders such as regulators, clinicians, public health experts, and policymakers on the bottlenecks and the fragmentation and duplication in the current pathway, and then identify possible solutions to overcome these barriers that impede the rapid and timely licensing and introduction to use of point-of-care diagnostics. And then based on the outcomes of all these consultations and mapping, we will then develop policy briefs for a regulatory policy framework to accelerate licensing and introduction to use of new quality assured point-of-care tests. And so this is the timeline for our project, and it's been delayed because of the COVID pandemic, but we are now starting the regional consultations, and the Asian one, as you heard, the Cameroon one was for Africa was last week, and the Asian one will take place early next year. We already had an industry consultation in February of 2020 before the lockdowns, and so it was up to us in the first quarter of next year to consolidate all the findings and plan a high-level meeting in London early March of next year in order to consider the framework for acceleration. And we welcome our partners in this project with Africa CDC as our focal point in Africa, Aladif as our focal point in Latin America, and ASEAN as our focal point in Asia. And so now for our consultation here, our objectives are to understand the need for accelerating and increasing access in this region, and to be able to brainstorm on the options for accelerating access with new technologies and new environments, and to be able to agree on options to move forward. So with that, I thank you very much, and back to you, Carlos.
Thank you, Rosana.
Obrigado, Rosana. Essa é uma excelente forma para entendermos o que está acontecendo com o nosso projeto. E para que possamos ver quais são os gargalos que precisamos aqui no Brasil, a Rosana com a Aladiv, nós fizemos uma consulta piloto com resultados excelentes. E uma das ferramentas que geralmente utilizamos é uma ferramenta de simulação. essas simulações
shoes of somebody else is actually to think differently and see the same problem that sometimes it's invisible. So we are now going to show to you the preparation for a simulation exercise and one kind of example. Thanks to our colleagues from Peru, they did 3 different examples with different exercises. We're going to show one after this initial video, just a short idea. And that's what we are going to do in the countries, because the best is really to have in-person exercise of the simulation in order to understand the key points and what we can actually do all together to overcome. Alguns pontos agora em termos de...
Now talking about some attention points. Please, if you wish to ask questions, make sure you send them via chat or through the Q&A functionality. Second message is we have simultaneous translation for Spanish and English and Portuguese. On the bottom portion of your screen, you find an icon called Interpretation, and you can select your preferred language through there. So having said that, I would like to thank Rosana for presenting her talk. And now I will invite you to watch a video that talks about the impact that we have had in education and in other fronts during the pandemic. And after that, I will show a simulation that was conducted in Peru. The video, please. There's no audio in the video.
Yeah, and this is one of the most thorny problems, most difficult problems, I think, with COVID-19, because and for the reasons that I think are very obvious to everybody, which is that first of all, everybody has different levels of risk tolerance. And by everybody, I mean different societies. We see, for example, the regions of the world, like the Special Administrative Region in Hong Kong and in New Zealand, and places where people are striving to have zero COVID, and you have very little tolerance as a society for it. And then you have other countries, like many parts of the United States, that are essentially saying, we're willing to live with this, and it's not a problem. So there's a societal risk tolerance issue. And then there's an individual risk tolerance issue. We have a huge problem in New York City that many of the populations that benefit most from, free, widely available public school system are from communities of people who tend to be very poor and disadvantaged. And they don't trust that their school will actually keep their children safe. So we also have individual trust issues about the schools. And so even if we say we're willing to tolerate infections, many individual families will say, no, they don't trust that because their grandmother is sick and they live at home with them. And so therefore they will simply not go to school. And that gets to the third issue, which is that we don't have a good way of measuring the harm from children not being in school itself. And so this becomes a very imbalanced risk calculation, because we're very easy to quantify the number of infections or hospitalizations from COVID-19 that occur in a school community. But you cannot add up very quickly and accurately the loss of education.
One of the major challenges when we were affected by the COVID that was last year was how can we respond to the COVID-19 with 3 different and specific missions. The first one, of course, was to control the spread of the virus. The second one, to limit the mortality due to the COVID-19. And last but not the least, to limit the socio-economic impact of this disease. To limit the spread, we decided to invest significantly on testing. And by testing, initially we meant molecular testing, as it has been suggested and supported by the World Health Organization. So in a short time, we were able to have 14 molecular labs in 9 of the 10 regions in Cameroon, which was already something great. However, we quickly realized that was not enough because we have delayed to receive the result. It was starting from 1 week, sometimes 2 weeks. And within that time, you cannot, one, take care of your patient, and two, you cannot control the spread of the virus. So we decided as a country, one, to evaluate the rapid test, and two, based on the result, to implement them. And we did that successfully to the extent that 6 patients confirmed positive out of 10 in Cameroon were confirmed by a rapid test based on our national algorithm.
It is unfortunate, I think, that PCR and antigen have been sort of characterized as one is good and one is bad. And to the extent that I think, unfortunately, antigen testing has in some people's minds been thought of as something wholly inaccurate and very second rate. Actually, antigen testing has the new antigen test, for instance, have a specificity that is the ability to correctly identify a negative test as good as PCR, which is often what we want because we want to know people are disease-free. And of course, that real difference in aviation, for instance, in travel, we want disease-free people. We're sticking them in a metal tube together. There's an increased risk of transmission there. So antigen tests are actually as good as the nucleic acid amplification test, the PCR tests, for an awful lot of purposes. PCR has a completely different set of advantages. It takes longer. It will often be done with multiple probes into different parts of the virus genome, and so can often give us some interesting characterization. It can also give us an idea of the viral load, so it can tell us something about what part of disease processes people are in, and will usually preserve the specimen that's used so that we can put it into a formal genetic sequencing test. So they're very different. They take different times. They both have very, very good specificities. That's the ability to correctly detect negatives. There's a bit of a difference in the sensitivity, but much of the sensitivity of testing depends upon how good a sample you get to start with. If you don't get a good sample, the test's going to be rubbish, whatever you do. But above all, the time difference. If you want to rely on a negative test, the ability of that negative test to hold good declines over time after the test is taken. So using an antigen-based test done as close to the point of travel as possible gives the best assurance that people are in actual fact not infected and not infectious during the travel period than a test that is done, say, 2, 3, 4 days beforehand, which will then have very, very limited reliability. So, the thing is, they're both excellent tools. You need to know what the characteristics of performance are, and you've got to pick the one that's suitable for the job that you need doing. And remember, the job that you need doing might be, has somebody been infected, but equally, is somebody not infected? Those are 2 important outcomes.
Bom, peço desculpas pelo.
I apologize for the technical mistake. The video will be made available together with the rest of the presentation, but I hope you are able to get an idea of what we are talking about. Every time we do an activity like this, every time we do a public consultation, basically we try to identify the existing problems that today could act as a barrier for the arrival of new products, and what do we actually need to do? This exercise is done with different stakeholders that are part of the public health discussion: regulators, policymakers for the health sector, the industry, patient groups, labs, and other stakeholders. Because the need is to raise awareness among all of them that in reality we have a common goal. Our goal is to provide access to quality products that will make a difference. After all, an early and accurate diagnosis can lead to a more effective treatment, and that became very clear during the pandemic. To talk about one of these barriers, actually a standard that was created and that ended up generating a lot of problems that we didn't predict, I would like to invite you to watch a second video to show you what is the impact that lives suffer because of a decision like this. This was done in a simulation, by the way.
Hola, ¿estás ahí? ¿Cómo estás? ¿Dónde estás? Estoy muy preocupada. ¿Por qué aún no has llegado?
Hey there, I'm worried. Did you get there? Yes, I also have a huge problem. I'm sorry it took me so long to get back to you. It will take me longer than normal to get back to you. Because of the pandemic, all the truck drivers, not just me, we do not have the PCR tests available. And they take so long. It takes about 30 minutes. So I've been here for 10 days now. I'm in the middle of the border. I cannot go back. I cannot go forward. And if I go home, they won't pay me. They do not recognize our work. So this is very, very difficult situation. I wanted to call you, see how you were doing. How are the kids? Well, we're good. The schools are closed, but the kids are with me. I did not go to work. We're okay because we're together at home, but you have to take care of yourself so that you do not, get exposed, because the virus is very dangerous and I do not want anything happening to you. Kids are stressed out. I do not know what to do with them, really. They want to play, they want to go out, and I have to explain to them that this virus is killing a lot of people, but they do not understand. They're too small. We do not have any food. I do not have any money to buy more. There's nothing left? No, there's nothing left. We do not have anything. I've already asked the neighbors to buy a few things, but we have nothing. And the neighbors do not have money or food anymore. And here in the community, in the neighborhood, we don't know. We have no idea what to do. I'm pretty scared. I do not want to go out because of the virus, and I do not want to, expose the kids. I was waiting for you to come back to figure out what we're going to do, and I was hoping that you would bring some money for us to buy other things. Yes, I wanted to get back earlier, but I have to wait about 30 days, and if I go back, I won't get paid. So I don't think I can go back now. So what are we going to do? What are we going to do with the kids? They're scared. They want to see you. They miss you. They have no idea what's going on. And I have no idea what I'm going to do about food. We have no food anymore. Oh, it's a shame. It's terrible. Just tell the kids I'm good, that I'm going to figure something out. I have a friend that maybe I could call, and they have something they could help. So take care. Okay, take care of yourself. Take care too. Bye. So you've seen that that's a simulation and it looks like a joke, but this problem with the borders is more severe than we think. Due to the Omicron variant, we've seen what happened with the borders last week. So do we have different tools? Was that really necessary? This is some of the topics that we have to discuss. Today, we already have tools that can make a difference. I understand that today with COVID and the PCR and the antigen tests and everything else, we already have a broad range of options.
Bom, vocês fiquem também à vontade até para trazer algumas questões.
Well, just to let you know, please send us questions if you have through our chat box or the Q&A functionality. I don't think Rosanna's on right now, so let's move on to our next session then, which is about the Inter-American Coalition for Regulatory Convergence and their work with good regulatory practices. So I would like to invite Sandra Lydia Gonzalez, who is responsible for the coalition and has been doing a fantastic job with different efforts with the regulatory actors and stakeholders in the region. Sandra, the floor is yours. Thank you so much, Carlos. I would like to share my screen with you right now then. I'm not sure if you can already see my screen and my presentation. Could you confirm that you can see my presentation? Not yet. Okay, just 1 second, please.
Ahora sí la ven.
Do we have it? Can you see my presentation? Okay, perfect. Thank you. It's not in presentation mode yet, so let me just correct that. 1 second, please.
Ok. ¿Quedó correcto ahora?
Okay, all good. Okay, so perfect. Thank you so much. So thanks again for having me. Thanks for having the IACRC to be part of this event. So with all the efforts that we have done, we know that we have a lot of challenges to deal with, but we still are able to contribute so that in the short, medium, and long term, we can advance in a more sustainable way for the regulatory convergence and use some benefits that we have learned. Today, I'm going to talk a little bit about the coalition, the good regulatory practices, and the actions that the IACRC does. So I would like to share with you what the coalition is, which gathers the stakeholders in the regulatory convergence sector, including representatives from 10 different countries and 17 associations and chambers. We also work collaboratively with 6 other standard developing organizations. We want to have one standard accepted across the Western Hemisphere, and our mission is to contribute and collaborate so that the regulatory technology and standards can contribute to facilitate access to innovative medical devices. With that, the elements necessary for the convergence are good regulatory practices, and these practices are about the quality and consistency of the process that has to be conducted to update standards. With that, we need the coordination of all sectors involved, both in the government and also in private sector, so that all these standards are conducted in an open and transparent way with the participation of the stakeholders, and that the results consider the international standards based on science that has the best norms and regulations. The regulatory process has different stages in which each stakeholder has a main role, but each and every one has a different participation, and the participation of the actors has an importance to guarantee all the points of view and experiences and all data pieces are considered. For that, the World Trade Organization generated principles to develop and manage the regulatory technical standards. With that, we have to consider transparency, the use of science-based data, and focusing on the product that is being regulated. One of the important aspects is the impact and the evaluation of the regulatory impact to guarantee that all variables are being considered whenever this assessment is conducted. This process has to consider all the resources available to identify what is the best alternative regarding the sustainability within the government processes to develop and implement those standards. We must pay attention to limit the action of different stakeholders. This has become very clear during the pandemic, where we see a huge dependency on global aspects. So it's important to guarantee that regulations consider within their construction the international barriers. When we evaluate a regulation within all that cycle until the implementation and the assessment of the regulation, to guarantee that the proposed offer complied with the objectives that was designed to. We can also make the different changes that are needed. In order to do that effectively, we also recommend the implementation, the existence of a coordination body within each government. So the idea here, going back to the regulatory impact assessment, we have to evaluate the impact of the regulations on the market. And the idea is to really quantify the benefits, the costs associated to that, in order to consider tangible, but both also intangible variables whenever formulating norms and standards. These regulations may have a very positive impact or also a negative impact regarding international trade. That's why the impossibility of different patients have access to medical devices. The World Trade Organization, together with other actors, promoted a project to incorporate transparency and points of view of the international community, and that generated different mechanisms to identify the regulatory proposals that are, and all countries, signatory countries, have to comply with the processes, and it's a co-responsible project from governments and the private sector to feed the tool that is made available by the committee to diminish the barriers. This is a tool called ePing, and it's available to all people interested. Well, regarding the good regulatory practices, it's clear that good regulatory practices are a fundamental tool so that we have effective tools and standards that are not restricted to the trade. And with that, we have to guarantee that both industries and regulatory agencies are on the same page and have the same knowledge and understanding of what that means. So we have to develop skills and also implement procedures in order to guarantee the correct implementation and compliance of all these international obligations that are related to the World Trade Organization, and also to develop for the economic development of all countries that are part of it, and also countries that are part of the region and their obligations with their commerce and trade processes that are already incorporating good regulatory practices in their statutes. So with that, we will be able to have a good regulation based on international standards, based on transparent processes, and that will have a definitely positive impact on the regulation of medical devices. This is a process that requires interaction of different stakeholders. The WHO, its guidelines and frameworks published that are fundamental to the countries. And they started in the month of April with their guidelines of good regulatory practices that brings this conversation closer to health regulatory bodies that were not so close to that, because most of that talk was done by commercial actors. So now we have that conversation closer to the health regulators, and we will be able to advance faster. Obviously, with the legal standards promoted by the global medtech industry and all other regulatory bodies, and the participation of government representatives and the private sector and international partnership like the American Technology Alliance. With all of that, we're able to collaborate so that all stakeholders are aligned with their proposals to advance towards regulatory conversions and implementation of good regulatory practices, together with the World Trade Organization and US aid. So with that, we are able to build those capacities between different stakeholders. So we try to promote all these capabilities through making resources available and developing tools that are available on the IACRC website. We also have to develop different materials and positioning to bring that to different countries and start conversation with different countries and develop new sessions of training that are both general and specific per country, so that all stakeholders know what to do in order to implement good regulatory practices on their day-to-day practice. One of the important things is the access of information both in Portuguese and Spanish, because we know that nowadays language is a barrier to advance in these issues. We know the efforts of different institutions to make materials available in other languages. We are also aware of the time that it takes, and that's why the IACRC has translated several documents that we consider very important.
In this slide, you can see and access our website, and among its contents, we have information regarding the international standardization, good regulatory practices, and transparency in trade. On our website, you also find all the materials and tools, all the training programs we have produced, so all stakeholders can benefit. We have trainings on good regulatory practices and other trainings focusing specifically on Brazil, Colombia, Chile, Mexico, and Peru. We have host sessions with different regulatory agencies, and we have planned a number of webinars on MDSAP, ISO 13485, with the participation of the FDA and VISA and ANIMAT. So all the countries that are working to update their models can have visibility and knowledge how other parts of the world are working. And we also have the documents with our official statements. Regarding training, on the slide, you have the direct links to each of the training sessions that are available on our website. And this is available in the Coalition website. Regarding good regulatory practices per country, here you'll find the links to all the training sessions that we have had. And you can access these trainings in Spanish and in English. Now, these are the links for all the sessions we have had with different regulatory agencies. And I would like to invite you to a session that will happen tomorrow. It will be the first of a series of sessions we will have with FDA and other stakeholders to discuss the use of international standards and the assessment of conformity that will be focusing on different stakeholders in Latin America. Regarding different documents that we have available, they are all translated to Portuguese and Spanish, and you can find them on the links on these slides. They were produced by the World Health Organization and 3 others that are available in Portuguese, also from WHO. Regarding our official statements, we have one about the law of pharmaceutical products, number 2 from Chile, that will allow us to regulate medical devices in Chile, because as you know, this regulation is quite limited right now, and it encompasses several products. In Ecuador, we have the regulation on traceability. We have identified that there is a very close relation between the recommendation and international standards, and very specific limitations regarding the identification systems with optical readers that can be complicated. And this has also has to do with how these regulations are operated and with a broader or less broad implementation of the standards. With that, I conclude my presentation. I'm open for questions, and if I'm always available to help you in your efforts. Excellent. This has been an excellent presentation, Sandra. Thank you. And I have some questions. Not to say how many countries are already participating and the recent accomplishments you all have had. If you could please talk about that. Yes, thank you very much, Carlos. Currently, we have 10 countries that are members of our coalition. Of course, we want to include all Latin American countries, but one of the important challenges we face is the lack of associations, especially in Central America. As we know, most of the distribution processes are done through distributors. So it becomes a more complex interaction. But we hope that the scenario evolves and they can also have their representative institution. And besides that, we have some other specific challenges. I say that in terms of advancements and accomplishments, or maybe the most recent and important accomplishment we have had is that last week on December 1st, we got the approval. I'm sorry, actually, by December 1st, the Global Harmonization Working Party accepted our proposal to turn them into an institution that would be connected to us. And in the same ceremony, FDA became part of the same working part. And we are very happy to see that happening because only by working in a collaborative fashion, we can find the knowledge that will allow us to use all the resources more effectively, working for the same common goal. I would say that these are some of the most important successes we have had. A project that is part of the coalition is the Regulatory Convergency Project for Medical Devices for COVID-19, as was mentioned in the beginning of the event. And the coalition is a member that is executing this strategy, and we have made important investments in some countries in Latin America, talking specifically now about Colombia and Mexico. And we are supporting the development processes of new standards and the development of good regulatory practices. So they are developed considering quality assurance elements that define the way the regulatory process is used in order to comply with all these standards. So in the end, benefits are more efficient because working together with different levels of government. For example, in Colombia, the National Department of Development, the Ministry of Health. For Mexico, working with COFEPRIS, with CONAMER. And all this joint work allows us to collaborate together, to collaborate with different government institutions, because by facilitating communication and access to resources, we have a positive impact in the development of new standards or in the update of the current standards. Now we stop talking exclusively about regulation and start thinking about the advantages that this can have for trade and the economic order. So in this sense, for regulation, today we have the use of tools that are well known by all of us. Reliance was one of these tools used during the pandemic, and so many others. But something that wasn't mentioned before was the use of standards for regulatory purposes. And inside the coalition, we have a very nice project, a project that was taken to 3 countries together with Aladiv, and now on the second stage will include 4 more countries to identify which norms or standards have already been incorporated by the countries and by some reason are not being properly followed, but they could be. Reducing time to access new products, and of course to improve the health scenario in that country. The World Trade Organization is a great partner we have in conducting this work, right? Sandra, thank you very much for your participation. It has been excellent. Would you like to say any final remarks? Yes, and talking specifically about what you just said, this collaborative effort in the international scenario, we are certain that we are starting to see all the positive spin-offs. We work collaboratively with WHO, with the Pan American Organization of Health, with the World Bank, with the American Business Dialogue. So we can count on their resources and the knowledge from the essential stakeholders so we can develop our abilities in the region. And one important aspect that maybe the pandemic helped us realize, and with initiatives of WHO and the good practices guidelines that were published, is how we can use international standards. And it's an essential work because many times we see that they are used as a foundation, but eventually they need some type of adaptation according to the country's specificities. And in the end, that limits the possibility of access and it adds cost to this process in the country, making it impossible sometimes. So this collaborative work with all these different entities definitely will help us with a higher participation of different regulatory agencies and private stakeholders to the development of these standards. So we can contribute for the update of these standards and the possibility of incorporating them into different regulatory systems. So once again, thank you for the invitation, and I'm available if you have any questions or if you need me somehow. Excellent. Thank you, Sandra. It has been a pleasure to have you with us. By request, the link to the coalition website is on the chat. I invite you all to get to know it. It's a fantastic work that is developed by a brilliant team, and they have been able to make great advancements. The work on regulatory convergence is only possible with the participation of everyone. So now I'm going to start our next session. It's going to be a roundtable that is going to talk about COVID. Lessons learned for the future. We're going to have Rosanna Peeling from the London School, Alex Costa representing UNICEF, and Marcela Abreu representing Anvisa. I would like to invite Rosanna to do a quick introduction on the topic, and then Alex, and after that Marcela will make their initial remarks, and we end the session with all three of them together so we can have a final discussion. So Rosanna, the floor is yours.
Great, thank you very much. And I'd just like to start by showing a few slides to illustrate how very practical lessons that we've learned from the pandemic. And it's often said that pandemics actually don't create new problems. They just make us face the problems that we've long ignored. And so we've seen in every country, whether it's a rich country or a poor country, that COVID has really exposed the fault lines in the healthcare system and all the inequities in access to life-saving commodities, which include diagnostics and medical devices, drugs, and vaccines, as well as PPTs, etc. And that the general lesson from countries is that they need to be building self-reliance in the manufacture of these life-saving commodities. But then not every country could do that. Maybe it could be done on a regional basis, and it must be done with really good quality standards. And then a third very big lesson for all of us is that when we talk about public health, we used to say, you know, public health conditions or messages, we just need to convey them to the public. We tell the public what to do and they'll do it. but we learned from the pandemic that this is not true. The public should really be given the knowledge and the tools in order to be more responsible to do their part in the pandemic. Now, just very concrete examples of what we could benefit from the pandemic and for building a more stronger antimicrobial resistance program. As I mentioned in my previous talk, the pandemic has really pushed back a lot of progress we've made with antimicrobial resistance programs because so much antibiotic was given to COVID patients. But there are good things that we could learn from the pandemic that we could use to build a stronger antimicrobial resistance program, such as messaging, to make people aware that global crisis can happen and it would affect all of us. And because we still have many people that are not aware of antimicrobial resistance. And then the kind of messaging skills that governments and other partners have honed in order to bring about behavior change. We could use the same thing to bring about behavior change that are needed for antimicrobial resistance. And then for One Health approach, we've always said that for antimicrobial resistance, we need to work with the animal sector, agriculture, and the environment. And now with pandemics, we know a lot of the viruses come from the animal sector. We need to be doing sewage monitoring rather than individual patient or individual monitoring in communities. Doing that kind of approach is a new way that we should be working at. And then building capacity, as I mentioned before, we've seen that we can now have the convergence of technologies for diagnostics, IT, and communications to build these dashboards so that everyone can be aware of the progress we're making or not making, and also to monitor how effective interventions have been. So I think that in terms of, in general, for diagnostics, we want to advocate countries now that we're trying to cope with living with the virus. We need to think about building a diagnostic system that is connected from the top to the bottom, from the very sophisticated reference labs to point of care testing facilities in the communities or even self-testing. That whole connected diagnostic system should form the backbone of a strong and resilient healthcare system that would provide equitable access to diagnostic testing and screening, better clinical care and rational use of antimicrobial medicines, and that, with apps that clinicians can use to look at the local epidemiology of a particular disease, we could actually help clinicians to make better decisions because they can interpret test results in the context of the local epidemiology. That system would form the eyes and the ears of the healthcare system to provide early alerts of potential outbreaks of anything that's unusual happening within the healthcare system, and that we have a dashboard that could help us daily to display the information that can inform the public and all the managers in terms of policy makers to help have a collective action on whether it's antimicrobial resistance or HIV or a particular disease or outbreaks. We need to have some means of working together, and that this connected system, as I said before, would allow testing data to be turned into real-time intelligence to inform control strategies. So in a very practical way, we've seen that the COVID pandemic, many countries have increased their molecular testing capability. They are now allowing more self-testing. They are building stronger surveillance systems in order to transmit the information more efficiently. And also they've now got really good skills for public messaging, for public health. And so these are things that would benefit in a positive way from now on. So that's the end of my presentation. Thank you.
Thank you, Rosanna. It's great to have this opening so we can evolve. And what we see is exactly a change in technology and change in the way we actually look at traditional businesses. And the pandemic can probably not have created this, but for sure they accelerated a lot. Agora, eu gostaria de convidar o Alex Costa.
So I would like to invite now Alex Costa. He's responsible for the legislative issues at UNICEF. Alex is Brazilian. He is in New York. He was part of the WHO in Cambodia and other countries and has a brilliant career in diagnostics. So Alex, welcome. The floor is yours. Thanks for inviting, or for being here, and the floor is yours. You were born in Brasilia, right? I was born in Sao Paulo, grew up in Belo Horizonte, and then went to Brasilia. I'm trying to share my slides here, but I cannot see my screen right now. 1 second, please. I have sent my presentation to you guys as well, so. I sent it by email.
Um instante. Oi? Só um instantinho.
Desculpa a inconveniência, não sei porquê. Eu não consigo nem ver a minha tela.
We apologize for that, and we will be back shortly. Here we go.
Bem, boa tarde, todo mundo.
Okay, so good afternoon, everyone.
I'll do the presentation in English because the slides are in English, and I'll do it slowly so the translator will be able to follow it. Next slide. I think the first thing that comes to my mind when I think in terms of lessons for the future is that we have to learn the lessons from the past, which I think we're failing to do. So this slide here shows the timeline for viral outbreaks in the last 20 years. And as you can see, there has been 16 viral outbreaks of public health importance in the last 20 years. And it seems that the frequency with which these outbreaks are happening is increasing. It could be because of better surveillance systems and data reporting. It could also be a combination of factors since we're accelerating habitat degradation, increasing animal farming, and creating opportunities for zoonotic diseases to jump the animal-human barrier, combined with the fact that we're traveling globally more than ever, which really increases the probability of exposure to emerging pathogens. But in all this, the point I wanted to make is actually at the bottom, that in spite of the fact that we all know that diagnostics are absolutely key or is an essential tool for outbreak response, outbreak control, diagnostics have remained neglected as an accessory tool in the public health system. Next slide, please. So we know the diagnostic tests are essential, and I think Rosanna just mentioned this, that they are basically the eyes and the ears of the current pandemic. Without diagnostic testing, we do not know who is infected, how the virus is spreading, and how it's mutating. And even people who are aware of diagnostics sometimes fail to understand the diversity of roles the diagnostics plays in disease surveillance. And actually, there are two main roles. You can think of patient management, which is patient diagnosis and treatment, and then the other one would be the public health element of diagnostics, which involves contact tracing, surveillance in order to detect outbreaks, the genetic epidemiology to identify variants and to determine the vaccine efficacy. Diagnostics are critical for safety in schools, in the workplace, and in travel. And it's also from an immunity point of view to determine the epidemiological status of the population, actually to determine the immunological status of the population in order to inform, let's say, the rollout of vaccines, as well as to determine whether immunity is waning and to introduce boosters. I think we all have a responsibility to educate people around us, especially those working in the public health system, about the different roles that diagnostics have to play. And unfortunately, what we see happening now is, at least in the response to COVID-19, is how dominant the vaccine narrative has been. Sometimes I ask people, how many vaccines or vaccine doses have you taken? And how many times have you been tested? Right there, you see the disparity, that some people have not even been vaccinated, but they've been tested many times. Others have been vaccinated twice and have had a booster 3 times, as opposed to sometimes a dozen or more different tests. Next slide, please. So one of the things that we have learned in this response to COVID-19 that I think is quite important for the future is that we continue to operate within silos. We think in terms of diagnostics or vaccines or therapeutics or health systems, when in fact what we really need is an integrated response. None of these tools will solve the problem. And the same will be applied for future pandemics as well. And in this slide, as an example, you can see diagnostics in the middle playing a role on one hand, for example, on the left side for therapeutics, to actually better inform treatment strategies. It goes from the preclinical trials in which you basically have to diagnose the status of the patients before you enroll them in the trials, but all the way to test and treat strategies, which are very important right now, because if we misuse the new antiviral drugs that are coming into the market, we're likely going to see the emergence of drug resistance very clearly, very, very soon, as we have seen for HIV and antibiotic resistance. And on the right side, you can see that the use of diagnostics is quite important for vaccine deployment as well. Before the availability of vaccines, they're important to the development of preclinical trials and clinical trials, and ultimately, it's quite important as well when vaccines are limited to inform a more effective vaccine deployment strategy, where you first vaccinate people who are more vulnerable or who have not been exposed to the pathogen. Next slide. The other element that we have seen in the past, and we see this more than ever before, is the importance of integrating social sciences into the response. You can't see the elements that are shown on the left, but I believe you're going to get the presentation, so be able to see it. But in the context of the ACT-A accelerator, UNICEF has been mapping a number of different factors, a number of different challenges for the uptake of diagnostics for COVID-19. And many of these are directly related to the epidemic of misinformation that we are facing along with the pandemic of COVID-19. So it really speaks about the importance of deploying an advocacy and communication strategy and engaging with communities in order to understand the drivers of their behaviors, to address the diagnostics hesitancy, as well as stigma and discrimination that could be associated with a positive COVID-19 diagnostics or with a positive test result from whatever disease. It's important to educate people in general and very importantly, decision makers on the roles of diagnostics, and to promote testing as an essential part of the response. Next slide. So another thing that it's very critical at this point is it's necessary, absolutely necessary to increase investments in diagnostics. And these investments go in a number of different directions. So we need investments in research and development of diagnostics, specifically molecular diagnostics, such as PCR and genomic sequencing, that can be quickly adapted to respond to emerging pathogens. As we have seen, the first tests to become available were PCR tests. The machines are globally available, and it's a test that's very easy to adapt. The second element would be to invest in digital technologies to support diagnostics. That includes interpretation of results when it's not very clear and subject to error, human error, quality management of these results, data management. It's very important for the results to be reported back to national authorities in order to monitor the epidemiological situation of what's happening in the country, for supply management, among other reasons. The third element of investment here is point of care testing technologies, such as, in this specific case for COVID-19, antigen RDTs and self-testing, because that allows decentralization of testing outside laboratories, outside the healthcare, and it increases access to testing, let's say at the community level, for example. This is something that there's a big push happening right now for COVID-19, but it's something that we're learning is very important going forward. And the last element here is investment in the ecosystem around diagnostics. You can't really sustain diagnostics or decentralization of diagnostics, for example, if you don't invest in the systems that are necessary to support it. So specimen referral and transportation, human resource capacity and task shifting, supply chain management, data management, biosafety are some of the examples. So here's another example of a lesson that we haven't learned. Human resource capacity for diagnostics has been a problem for decades, and it has been a bottleneck in many responses we had before, and this is happening again. Even with the technology available, the costs dropping, we're facing a bottleneck in low and middle income countries, which is the lack of a labor force that is capable of performing the diagnostic tests. It's not sufficient to have enough tests if you don't have enough people, if you don't have a career path, if governments do not invest in their own labor force in order to enable a faster response. Next slide. There's this saying in English that we're building the plane while we fly it. This is what's happening now with COVID is a very good example of how challenging it is to understand how to effectively deploy diagnostics when there are so many unknowns. We have so many questions, and these questions continue to emerge on a regular basis because we're dealing with a very dynamic situation, a disease which is a moving target, a pathogen that's constantly mutating, and diagnostic technologies along with other technologies that are constantly being developed as well. So in some ways, this has taken some of the credit away from the science, which is not accurate, because I think it's very important to understand that we do not have many answers, but that's the reason why it's so important to invest in operational and implementation research to help inform the deployment of diagnostics, the development and deployment of diagnostics as we are responding to outbreaks and pandemics. Next slide. I think the other lesson that we have learned, and it's quite important for the future, is that the process of development of international guidance, which is led by the WHO, may not be as fit for purpose for a situation like this with COVID-19 and such a dynamic situation as it is for for a situation that is not as complex, as dynamic as this one. I think there were several moments, and we're still facing this, in which countries and governments are begging for more guidance on how to utilize diagnostics and other tools, but the process for development takes such a long time, and it's based on evidence that's published in peer-reviewed journals, for example, that it limits the speed at which guidelines can be generated. And this could cost many deaths, because in absence of evidence, in absence of guidance, actually, in absence of guidance from international organizations, many countries will try to do the best that they can, which may not be appropriate. So I think there's a need for a more agile guideline development process to deal with a situation that is as dynamic as a pandemic is like this. And next slide, and I think that's my last one. And I think the last point going forward, it's something that Rosanna has just mentioned, is the importance of adopting a One Health approach. This pandemic has really exposed how the animal, the human, and environmental elements of human health, of One Health, are all interconnected. And I think the importance of diagnostics, although we're mostly talking about it here in the context of human health, it's really something that should expand to address animal health as well as environmental health. I think diagnostics has a much bigger role to play. And it is only when we adopt a One Health approach that we'll be able to effectively prevent and tackle some of these challenges that we're going to have going forward. One of the most important ones is antimicrobial resistance, as Rosanna just mentioned, which is really cannot be effectively addressed without a One Health approach. So that's one of the last points I want to make in terms of lessons learned. We have to adopt a One Health approach going forward. I'll stop here, and I'll be happy to join the panel discussion. Thank you.
Excellent, Alex. Thanks a lot. It's really a great presentation, great topics that you have brought, and I'm sure we're going to have a lot to discuss soon after Marcela's presentation. Marcela Abreu, gerente de diagnóstico in vitro da Anvisa, grande colaboradora da Aladiv também, já há vários anos, tem feito essa grande jornada conosco. E a Anvisa, este ano, mais do que nunca, esses 2 últimos anos, ela se esforçou.
Anvisa has worked really hard in order to make advancements and to ensure access to faster tests to the population. So, Marcela, the floor is yours. Thank you very much. Thank you, Carlos. First, I would like to greet everyone. I would like to greet the event organizers and thank you for the invitation to talk about the lessons learned when it comes to COVID-19. I don't know if my presentation already. I think it's working. So thinking about the lessons learned, this is always a great opportunity for us to remember that these are lessons that we have learned so far. Learning is a continuous program. We're still learning about this. So when we talk about new etiologic agents, as well mentioned by Rosanna and Alex, we are talking about situations that are part of development and they're part of our interaction with the environment. So we have very clear memories of other battles we had to face with the arrival of new etiological agents, and they're part of our recent memory. Maybe they were not valued as much as coronavirus was. So we have HIV, which also have an global importance. Between 2003 and 2006, we have the avian flu. The situation.
Empenho para a gente conseguir administrar, né, e controlar quadros como esse, as arboviroses, né, que nos anos de 2014 e 2015, além da febre amarela e da dengue, que já eram de grande relevância principalmente para os países tropicais. A gente
especially in
teve
tropical countries,
e do Zika vírus, né, que foi importante
regarding chikungunya and Zika virus that were very important because they led to microcephalia situations that were connected to this new agent. And also Mayara virus and new viruses that are coming up. So the coronavirus is not the first one, and it's not going to be the last one that we will face as we see the evolution of these pathogens. So what we've been seeing with the COVID-19 situation and the differences between this and other pandemics is that we have bigger challenges due to the proportion and intensity that it posed and the changes as well. So regarding COVID-19, we've seen a global need for the resources for everyone at the same time. Together with that, we had to work on new etiologic agents in an uncertainty situation. So we do not know that microorganism that well, so that we are able to make decisions to make access available, both in identifying and also measures to protect the society. So we have to have a constant surveillance to monitor the microorganism and how the knowledge is being built. So a collaborative action is very relevant within that context. And the first big lesson that the COVID-19 pandemic brought is the need to work on flexibility. Like previously mentioned, that the importance of IVDs is huge because it's not only at the forefront. When we talk about IVDs, that's involved within the whole chain of this process. So both for control and diagnostics of an agent, as well as to develop control measures and also monitoring the condition of a patient. There's also, on the other hand, the possibility to build knowledge so that we know more about the agent. We need to study it. We have to invest in research, and we have to use different products. So the importance of IVDs is at the forefront of strategic decision making, and it's important as well to monitor health as well. So regarding the regulatory environment, we've seen the prioritization of analysis. So the first thing we had to work on was to align the needs and access. Our starting point at Anvisa was to focus on the analysis of registration requests. When we started working on this framework, besides coronavirus, we had other respiratory viruses that were already known. And so we thought that we also needed a differential diagnosis. So we worked on current requests that we already had for coronavirus and other respiratory viruses, but with the increase in demand, we focused our efforts on products for coronavirus. So with that finding of an etiologic agent like that, we had as an option to identify the virus. We had the protocols that were shared, which was the CDC protocol and the Charité protocol that allowed countries to implement in-house methodologies, acquire inputs, and validate those inputs based on those protocols to be able to make products available commercially. We also had to work a second topic, which was agility in response. So we had a 15-day deadline to receive requests, and we were only able to meet that challenge due to the work of our in vitro diagnostics team. So we were able to meet that challenge, and we also worked with different bidding processes. So we were able to, so that we were able to make the products available on the market to fight the pandemic. We also identified the need to work on changing requirements, because with time we have more knowledge about a product, we are able to implement improvements, and we are able to follow up that evolution. Within a pandemic, we understood that some requirements had to be analyzed in a priority manner. Another thing that we worked on was the flexibilization on technical standards. With that, we were able to look at different contexts. We could not work only on registrations if we were not able to import the product to the country. So one of the main points that were involved in IVDs was the flexibilization and emergency use of products, so that we were able to analyze the product with limited sampling to authorize the product for the market within a year. Throughout this year, many companies were able to obtain more robust information about the product and convert that registration from an emergency use to a 10-year use. We also had to be flexible regarding the use of certain products because of the lockdown situation. And sometimes we were not able to conduct audits. And that's why we were accepting information from other regulatory agencies. Import of essential devices also had to be flexible, so that we were able to provide support to the market for those products that were considered essential. Pharmacies and drugstores also amplified their testing services, and that provided more capillarity in obtaining information about the health of the population. Within that context, we also worked to extend the expiration date of a product. Normally, we evaluate the stability of the product and we estimate an expiration date. Within the pandemic, we are talking about scarce resources. So if throughout time we are available to extend the expiration date, then those products have specific conditions and they are still, able to be used. So that flexibilization of technical regulation was very important for Anvisa as well. One other topic that we worked on was transparency. The access to information is essential so that we know and are able to make decisions based on data. And so we worked with BI panels that allow us to follow the demands received by Anvisa, understand the status of all the requests, have quick access to the consultation of products. We also thought of creating a chart of strategic decisions based on the type of sample, the type of product, the methodology used, which are the targets, and make that available on the Anvisa website, the instructions of use. We also worked on the program of monitoring the quality of products on the market. And that was an important initiative, both in terms of surveillance from the government and also the private sector to identify the need of this vigilance, because this is a collaborative work that has to be conducted by everyone together. So you can see this is the link to the panel. You can see it on the bottom of the screen. So here on top, you can see the timeline of the product, the time of response of the agency. You see the whole volume of information that you have of the products. And here's the status of evaluation of each product. So we have over 1,000 requests for registration of products. Of those, 70% were approved and 25% were denied. So in Brazil, this is data from November 23. We already had 436 products for antibodies specific for coronavirus, 107 molecular assays, and 145 antigen assays. This is a monitoring of the origin of the products. So you can see that we have several products coming from Asia, and also an important participation coming from Europe. So now we see that there's an important topic as well, which is knowledge. We had to work on points that focused on technical and scientific update. So we worked on exchange of knowledge with product developers. We had important meetings to meet those developers so that we had access to the knowledge and how the products were developed. We had meetings with regulatory agencies to understand the impact of variants and innovations on diagnostics products. We also had weekly meetings with our teams to exchange data. And we also worked on diversifying sources of scientific update. So technical update is something very relevant. And when we talk about risk scenarios and the evaluation, that has to be connected with communication and integration. So the first point was a need for everyone to adapt to working from home, and that impacted our work at Anvisa. And that has also to do with the integration of different areas that have interests in common. So we're talking about new stakeholders that are very important within the knowledge scenario regarding communication and integration. So we are dealing more with media, with the legislative and judiciary branches, the regulatory sector, researchers. So everyone is involved in this information scenario. We also have to follow up on international warnings. So we have to keep an eye on all the changes that are happening in the scientific context and the world scenario. So we have variants that are important, the issues related to the virus spread and control measures, and the profile of vaccination. So we have different stages within the pandemic. And so we have a technological trend as well, which is leverage, so to speak, to develop products like a type of point of care testing that we've seen grow in the sector. But now we've seen greater effort regarding that, and also softwares for medical devices and the use of artificial intelligence.
So I think that having said that, this is already part of the scenario, the whole biological setting. The need to adapt, it's a need to survival. We need to align these different elements. We need to realize where we are in terms of context so we can assess all the different issues that belong in such context and adapt to them. So adaptation is truly a matter of survival here. And I have a quote for you from a Brazilian philosopher called Mario Cortella. And I think this quote is related to the discussion we have had so far. There are no designated seats in the future. And for me, this is a reality when we talk about the diversity and how dynamic we are in terms of products and information. Because the reality today can be completely different tomorrow. It can be surpassed. So we need to grow, we need to be flexible and adapt to the new experiences that we have. And I would like to leave you with another quote that could help us guide many of the decisions we make. It is a quote that should guide our decision-making process. But on the other hand, this is a good quote to provoke your thinking, because there's no single answer to it. Because every time I need to make a decision, what is the best way to go? So thank you very much. That's what I had to share with all of you. Thank you, Marcela. This has been an amazing discussion panel because of the quality of the messages that all three of you presented. You all reinforced the need to constantly reassess our position, and we have received many questions from the audience. So now I'd like to invite Alex and Rosanna to open their cameras again so we can have a quick debate with some of the questions that were sent. One of them talks about the role of the antigen test. Not to the opening of borders, but for allowing a safe traffic.
Do nosso Zoom, ele pergunta exatamente, o Bruno, os testes nacionais aprovados pela Anvisa têm validade para entrar em outros países?
Have been approved by Anvisa are valid when entering other countries. And of course, he's thinking about national tests or tests that are produced here, or tests that have been approved here, tests that have been tested nationally, and then passengers are leaving the country with the result from the lab or from a pharmacy. So Marcela, if you could take that one. Thank you for the opportunity to participate in this discussion. But first, I think we need to understand some important elements. First, as mentioned by Dr. Alex before, there are different criteria that are established in different countries. The product evaluation criteria are different. In Brazil, we don't establish minimum performance levels for these products because of the way we have worked when it comes to accessing these products in the country. So they are evaluated regarding to what the manufacturer has designed for the product and what is stated in the instruction of use. And when we talk about an antigen test in the coronavirus setting, because we're still trying to get to know more about the virus, the tests are developed for different portions of the virus. So what is the risk that we can have related to this type of test? When it comes to different variants, if the product was developed for a portion that could include part of that variant, there could be some failures in the results, but that doesn't depend on the place where the product has been tested or approved. If that happened in Brazil or in a different country, that is not really what is at stake here. So there are still risks when it comes to diagnosis. We still don't have a clear path. Molecular assays are still safer because they are more specific in the virus identification, but they can also present flaws. So I think a test that is conducted in Brazil and approved in Brazil, its acceptance varies because it might not meet all the standards of the country to which the person is traveling to. In my understanding, Marcela, a traveler leaving Brazil, if the test is done in Brazil, if it's of course an approved test, the standards to travel will be met. And I think Anvisa has had a very careful approach in the products that are being sold and used in Brazil, especially when it comes to the surveillance aspects of them. Our assessment program for the coronavirus kite, which was a group effort by different institutions, helped Anvisa to have a better understanding of the performance of these tests. And also the work conducted has demonstrated that the products manufactured in Brazil are of good quality. And once individuals are tested, they have the results from a qualified professional that could serve for traveling. But I would like to know now from Rosanna and Alex how this works in other countries, because before there was a demand for PCR test plus a period of quarantine. But in more recent times, these measures have changed for a combination of an antigen test, in some countries even accepting a self-test, especially when they arrive at the country. So maybe if you could clarify a little bit more of that. Alex, please.
Mesmo mencionou, a situação
Carlos, as you mentioned, we are evolving very fast and we don't have a golden standard yet. So as the different national regulatory agencies approve an antigen test or a self-test, they become part of the national policy. But we don't have a standard for that. And that highlights the value of a regulatory cohesion, especially from the regional point of view. So the thing is,
a situação continua evoluindo de maneira muito dinâmica.
We're building the plane as we fly it, and the situation is still evolving. Rosanna?
Yes, I agree with what Marcela and Alex said. I think there are just too many countries with too many requirements that have become very confusing and complex. But one thing I would say is that if a country has approved a test for antigen tests or self-tests with a high specificity, because most of the antigen tests have comparable specificity to PCR, if not just a little bit lower, like 98% compared to PCR, then the negative predictive value of these tests become very high and are totally acceptable. And so what we need is a test, not to find a case, but to assure that a person is negative in order to travel or to attend an event, then antigen tests on the whole would suffice for now, even though we don't have very strict standards or international consensus on what to do. But I think that's the value. That's why antigen tests and self-tests have become so widely available, and people do use them just to assure themselves that they are still negative. And I think for most countries, if you're antigen negative, but we have reason to think that you have been in contact with the case or that you're symptomatic, then, and if you're antigen negative, then you should certainly go and have a PCR test done. But for most individuals in a community wanting to know whether they are negative or for the virus or not, an antigen test of reasonable specificity, such as 98% would, compared to PCR, would survive. And so this is what we can go on right now. Over.
Excellent. Nós temos trabalho muito interessante que é o
We have a very interesting work, something mentioned by Alex, with EPTE. It's part of a group that is working in all three areas: therapy, meaning drugs and monoclonal antibodies, antiretrovirus, and vaccines, where we have had a great evolution, and in the tests as well. And as he has demonstrated, there is a trend to try to, or there's an expectation to acquire more than 1 billion tests, in its majority fast tests, for developing countries that still need to monitor the evolution of the disease. And this is something that is already happening. Tomorrow, we will have a presentation from FIND, and they will talk exactly about that. They talk about that from the technology point of view, meaning R&D, up until the discussion of going into consumers' home, using that context of an auto test, which is another available tool we have. In the case of England and other countries, they use that to complement the testing process. Individuals arrive, and they can be tested at the moment of arrival, but they also take home some tests so they can check their status from time to time. So my question to you, Marcela, is how do you see this? How do you see the arrival of new technologies, so the point of care test, and how is Anvisa preparing in this technology horizon? And also thinking about new tests, new environments, a discussion that is being conducted by the review of one standard and the General Office of Services at Anvisa. I talked to the General Manager today, Guilherme, and he mentioned that pretty soon we will have a consolidation view on this discussion. But regarding the registration or the licensing area, how do you see the new technologies? And you've mentioned this in your presentation. We're not talking just about point of care testing, but we're talking about IT and the different softwares as medical devices for these new settings. Of course, not forgetting about the COVID auto test. Okay, so as I mentioned before, the point of care testing is the reality. It's here to stay. And it's a type of technology that is extremely relevant, especially when we talk about access, as long as it is used properly. So when we talk about point of care tests, there are some concerns from the regulatory perspective, and they include the professional training, the quality assurance controls that can be applied to these products. There is the issue of the infrastructure of the place that includes all the different steps of management and steps related to a specific infrastructure when it is required by these products. Because some products do require a specific infrastructure. So we need to do preventive maintenance, for example. And we need to manage data and data privacy of users as well. This is also an important element when we talk about sensitive information. We even have this connected to the general law of access to personal data in Brazil. There's a need to monitor the results of these tests. So truly, it is relevant, it is important, but it is a segment that is growing. So our work is to minimize the risks or errors in results that could be connected to the product or connected to the way these products are used. So we need to do some adaptations in the regulatory context so we can advance in expanding access to these type of products. When it comes to auto tests, we're talking specifically about issues connected to public policies. We cannot introduce an auto test for a disease that has a mandatory notification without a policy to clearly know the purpose of doing that, because we are talking about a lay user that will use the product under conditions that they don't control. They don't know the type of product, because we have assays for antigens, we have assays for antibodies as auto test products. So what do we expect with this type of information? Because if we don't assess that within a public policy context, we can also have the contrary effect of the work that we have done so far. So this information might not be valid due to problems in the execution of the test or for an improper use of the product, and that might lead us to question government actions. It can lead to raising questions regarding vaccines, because if you do an assessment right after a vaccination, results need to be interpreted differently, or you might interpret those results as you are already protected. We need to know more about the immunogenicity of these virus, how long it lasts, what is the minimum level of antibodies that you expect, what is the decay rate that is expected. So all these situations need to be known. So the public health policies need to have clear purposes so we can understand how much expanding access to a non-expert audience, because I'm not talking about public services here, I'm talking about health professionals that are trained. But in this case, we are talking to non-experts, people who don't have the basic knowledge to identify these different elements. So this work needs to be connected to information campaigns and connected to a clear purpose of why these products are being used. So Anvisa is not eliminating this type of assessment, and we are open to have this communication and this conversation with public policy makers so we can find the best way to face the pandemic. Because in the end, we are all searching for the same goal. We want to have the best result we can in fighting and controlling the virus. Excellent, Marcela. Thank you for your comments. And my question to Alex and Rosanna now is, how can this dilemma between a non-expert audience and health professionals is being dealt with in other countries? Maybe Alex, you can start.
Rosanna, why don't you go first?
Okay, Alex. So I think that this tension between a top-down approach of a notifiable disease that you must have control of who's doing the testing in order to know how many cases there are. So we've seen that with HIV, right? We've seen that for years, we do use a top-down approach for these communicable diseases that are notifiable. But then we realize, in spite of all our efforts, that we will not reach certain populations that are at most risk of transmission and acquisition and transmission. And that for the purpose of having a stronger disease control program and be able to eliminate HIV as a public health problem, we needed to have self-testing. And recognizing that self-testing, it's only an aid to diagnosis, is not a diagnostic test in itself, right? We're not saying anybody who tests at home has a positive test, that's diagnostic. That's not true. It's only an information as an aid to a diagnosis, because that diagnosis needs to be confirmed. And so a lot of work had gone into how making sure that whoever does self-testing, if they have any questions, they have hotlines to go to, or if they have a positive result, they must seek care and to confirm the diagnosis, etc. So all that had gone through, I think, the last 8 years for HIV. And there's a lot of lessons we can learn from there. And because now the pandemic, COVID-19, is affecting everyone. It's a respiratory infection, it's affecting everyone. We need to expand that thinking to say, you know, if I were a person who had gone to a wedding where you think that there's not enough public health measures of distancing, or people were not wearing face masks, and you're in a hyper-endemic setting, when you go home and you have an elderly parent at home or grandparents, it would be good if they have access to a test, just so that they know that they could be comforted in the fact that they are negative, in order to be able to have not to have to self-isolate after going to an event like this, or to work every day, etc. So I think there are certain circumstances that could complement this, even as vaccines are being rolled out. I was once asked, if you were sitting in a plane for a long trip, would you rather be sitting next to a person who's vaccinated or a person who's been tested in the last 24 hours? And I'd say definitely tested in the last 24 hours, because the vaccines are not preventing infection per se. And so, and people say, oh, what about a PCR test? But most countries require PCR tests within the 72 hours. And if I were working in a care home and constantly in touch with high-risk individuals, or care for, or in the hospital and care for high-risk individuals, within those 72 hours, there's a high likelihood that I may have acquired the infection. So I think there are all these different things that, you know, we can't resolve right now, but it's a matter of tolerance of risk. Every government has a different tolerance for risk. Individuals have different tolerance for risk. And we try to do the best we can. Alex?
Thanks, Susana. Eu gostaria de complementar algumas coisas que foram faladas. Por exemplo, a Marcela
I would
falou
like
sobre
to add a few points to what Marcela talked about self-test and what we've been seeing internationally, because everything is so dynamic. We know that these products are being developed and they're going to enter the market, and sometimes they are already in some countries. There is an effort of the Access to COVID-19 Accelerator to work with universities to model the use of self-tests in different situations, in different levels of transmission and different use cases. If you're doing that at a school or at a community where there's transmission, or whether it's in clusters. And that will inform the policies and the implementation and the operational research that has to be associated with these tests, so that we can confirm or refine the model. One other element that is involved as well, which is a synergy work, is the development of digital tools that may help, on the one hand, to reduce the errors related to the interpretation of tests, as well as help to inform the results to the public authorities of the country. If the results are read, for example, with an app on a smartphone, for example. So the idea is to help with the process of testing and interpretation of results and mitigate the errors that may be associated with that. And also, in general, the self-tests, as far as I know, are available for individuals. You can go into a pharmacy and buy one. It's not cheap, but it may not be accepted if I want to participate at an event or board an airplane. So the self-tests are for self-use, and if there's a positive result, or if the result has to be official, it has to be conducted by someone who's certified, whether it's in a laboratory or a drugstore. and has to have an official result. So the self-test is preliminary, not definitive, and it has to be confirmed by an official or agent or organization that is really certified to do that. Excellent, Alex. There are a lot of topics to debate, but one of the things that we are sure is that people stopped testing. In Brazil, we have been advancing a lot with vaccination, and so basically people think that they do not have to take tests anymore. So when Rosanna said that in a plane she'd rather sit next to someone who is tested because people sometimes when they are vaccinated, they do not have the risk of getting infected. And that's not true. We've seen cases of infection and reinfection. So the test provides an early and precise information about the status of the person, and then you can adopt measures, whether it's treatment or contact tracing and other measures. So we know that diagnostics are the best tool. The tests, the way are being developed, when they are out of the traditional environment, they show the people that are invisible to the system. So now some people are showing up and they would not go to, seek for care because they were not aware of that. And now they are going to the pharmacies, or they may go to a clinic, and they are going to seek care for people who are certified to do that. And so the self-test is an additional tool that can provide an alert so that people can take a different attitude. So we see that there are different technologies. What Marcela does, calling the policy makers, is very important. So now this event is an open space, these 2 days, to debate with people from Fiocruz. We've seen Claudio Majerovic already, asking questions. So we're going to have other authorities here. And so the idea is to promote to citizens, both visible and invisible to the system, the best tools. So with that, I would like to thank everyone. And I would like to leave the space open for final remarks to each of you. And we will keep working, and we count on you. Thank you very much. Marcela, Alex, Rosanna. So I'm going to start just by thanking you and congratulating you, because we have to have this space to debate these issues. Because if we only have one point of view and do not have other perspectives, those who develop a product have a purpose. Those who await a test result have an expectation. Those working in the regulatory sector have an eye for risk. So when we change our perspective for different points of view, then we're able to see things differently. So this is very important, a room like this one to talk about that, so that people are able to have more information about products, technologies, and applications, so that we're able to, question ourselves. What is the best way? What is the best decision, and why make that decision? Are we able to evaluate the impact and seek the best response? So I think this is what we really need, a room for debate, understand that there are differences when we compare, when I talk about an HIV test and a COVID test, these are different situations, but this is very important. And I would like to invite everyone to talk about anything, so that we make these rooms and spaces even more available. Thank you very much. Alex? I'm just going to repeat what Marcela said. I just, thank you so much for having me, for the opportunity to talk about something very important for all of us. And I'm really, really very impressed with the level of literacy, really, of regular people. So people know a lot more about diagnostics since the pandemic. 2-3 years ago, nobody knew what a PCR test was. Today, people who have no education in the health sector whatsoever are able to understand the differences and the limitations and benefits of each test. So this is an example of the opportunities that we have. Although the COVID pandemic has a huge impact, like an old Chinese saying, every crisis also poses an opportunity. So today, I think we have a huge opportunity to strengthen the diagnostic sector that were, exposed by the COVID pandemic. And so each and every one of us working in that sector have to recognize those opportunities to strengthen the diagnostic system, because the number of events, the number of infections and outbreaks and epidemics and pandemics is increasing, but the importance of diagnostics will also increase. So one example of that is the bacterial resistance, and it's a silent pandemic. It's been spreading for a long time now. And so my final remarks is that we working in the sector have to understand and see these opportunities to strengthen the system in the future.
Hi. So I'd like to echo what Marcela and Alex has already said. I mean, we're now facing a health environment that is so totally different than what we had before. As Alex said, we no longer can afford to work in silos. We need to have everybody understand everybody else's position. As Marcela said, a company has a different perspective. The regulators have a different perspective. Policymakers have a different perspective. So we need to, that's why we do these simulations to bring every different perspectives into the same room to try to, for people to understand the complex decisions that others have to make and be able to appreciate what the whole picture is. Then the other change in the health environment that's been gradually happening, but it's accelerating for us to face it, is the top-down approach versus grassroots up approach. And we now need to think about a combination of this and how to quickly learn about a different environment where we have both top-down and health grassroots approach work together. And so I really think this has been a really useful and very rich discussion that we could keep on moving forward. Thank you.
Thank you, Rosana. Bom, eu agradeço a todos. Foi realmente grande prazer ter.
Thank you so much. Thank you so much, everyone. It was a pleasure to moderate this panel. And now I would like to invite Ana Flavia Pires, Director of GermSure, who has experience both in the public and the private sector. She will conduct this panel about access, new technologies, and new environments of health. Thank you, Carlos, for having me. Congratulations on the event. This was a very interesting panel. And now it's important to discuss, new technologies and the self-testing. I believe that we will have self-testing in Brazil available very soon. And so now I would like to invite for this next panel, Cassiano Correr from Abra Pharma. And I would like to ask you all to make a quick introduction. And I would like to invite Pablo Moreira, Segundo Leon from Peru, Cesar Cano, and Dr. Elliot Cowan, who is our international speaker on this panel. Cassiano, are you ready? Over to you. Good afternoon, everyone. Can you all see me? Let me share my screen with you then. We can hear and see you very well. I would like you to make a quick introduction about yourself and then move on to your presentation, please. Well, thank you so much for having me. My name is Cassiano Correr. I'm a pharmacist. I'm also a technical consultant for Abra Pharma. I coordinate a program of pharmaceutical assistance. Abra Pharma is the Brazilian Association of Drugstore Chains. And I'm also CEO of Clinicar X, consulting on pharmacies and drugstores. So today I would like to talk about a case and share with you how the COVID testing has been going on in drugstores in Brazil. This is a study that was conducted this year evaluating the results of these tests and how the pharmacies and drugstores are working and offering this type of service to the population, following all the good practices in the health sector.
So first, just to give you an overview, if you're not used to the numbers, Abra Pharma is the Brazilian Association of Drugstore Chains. We have around 8,000 drugstores in all states, and talking specifically for COVID tests. Since last year, as soon as Anvisa granted authorization for drugstores to conduct COVID tests, we started offering that service. And so we have more than 4,300 pharmacies providing that service. And last year, we started to monitor these results through a weekly panel. And we have totaled more than almost 12 million tests being conducted since last year. And this weekly dashboard is very interesting because it tells us a little bit about the history of tests being done inside drugstores week after week. We are currently on week 79 of the process, and how this testing curve somehow also follows the pandemic curves, the different waves and the moments of peak of the pandemic, and now in the last few weeks with a gradual reduction in the volume of tests, of course related to the growing vaccination program in Brazil. But I would like to highlight one thing for you here. First, I would like to reinforce the fact that drugstores have followed the evolution in technology of tests in Brazil. Tests are an important tool when it comes to the role of drugstores and the fact that they remained open during the pandemic. We have had 3 generations of COVID tests being offered inside drugstores. A first generation with IgM and IgG antibodies, a second generation of tests with antigen tests, which without a doubt was the most used and most looked for test, and a third generation of more specific antibody tests for anti-spike tests that are being offered in these drugstores, but at a lower demand. So in order to assess the data and conduct a more in-depth study, what Abra Pharma did was to collect data from all the tests that were conducted from January to June 2021, and we conducted a retrospective study on the clinical data of such patients. Because all patients, they get a medical record, and the test is part of that medical record. And we conducted a large study with more than 3 million services provided in the first quarter of the years, conducted by more than 8,000 pharmacy professionals in more than 2,600 pharmacies in the chains that are associated to Abrapharma. So this study shows you sort of a clear picture of the disease in Brazil, and it is a scientific study that is being prepared for being published in an international journal since we have such a representative sample. So the role of drugstores in COVID tests has been debated extensively. And for millions of Brazilians, the story was pretty much like this. Once people would wake up or they started feeling certain symptoms, they was unsure, am I with COVID? Do I have COVID or not? What should I do now? And then drugstores became a new place for people to look for medical assistance, a place where they could find a qualified health professional and where they could find an initial or definitive answer to that problem, or especially that anxiety of feeling symptoms during the pandemic. This is an interesting service because it didn't exist before, and it's a service that has been provided to millions of Brazilians from all age groups, men and women, throughout the country. This is a profile of all the services, all the patients that were tested this year. So we are talking about a pretty much 50-50 division between men and women. Adults between 18 to 39 years of age represented almost half the patients that looked for this type of tests in drugstores. After them, adults between 40 and 59, and elderly who 60 years of age or older. But in general, drugstores were open to welcome patients from all age groups. Once patients got to the drugstores, in order to explain the service protocol, because it was more than just a test. Every patient, once they got to the drugstore, they were, of course, welcomed, and there was a protocol. And they were able to implement a unique protocol regardless of the region of the country. And even if they are private chains that are competitors among themselves, they were able to implement a single protocol that included an initial step with a clinical triage to identify the symptoms, a second step where the most appropriate test was recommended and conducted, and a third step of the protocol with the official result report and guidance and recommendations for the patient and possible referrals depending on the results. And talking about the specifically about the first part of the protocol, which is the clinic triage, all drugstores implemented a standard anamnesis based on information from the Ministry of Health. Pharmacists would ask a number of pre-designed questions. The answers were included in the software, and we were able to determine the probability of these symptoms being connected to a COVID infection, being connected to a severe respiratory syndrome, or maybe they could indicate that even though that patient had contact with positive cases or had a trip recently, that probably was not the case of a COVID infection. And this structured anamnesis gave us a clear picture of the disease itself. So patients that came to pharmacies or drugstores to do a test, they had cough, a runny nose, a sore throat, and a headache. These were the four most common symptoms reported by patients that are connected to a common flu as well. And also more specific symptoms like loss of a sense of smell or sense of taste that are more related to COVID-19 with a lower frequency of 6.5%. And if we compare the symptomatic cases according to age group, it's interesting to see how these initial symptoms were very similar regardless of the age group. So here in this graph, we see the percentage of patients presenting one symptom in the moment of the test, and on the x-axis, the different symptoms that were reported. And each line, each color represents a different age group, and they all have very similar symptoms with some small differences, like cough was more common in the elderly group, diarrhea was more common in children, So small differences between age groups, but very similar in general, regardless of the age group. So after the clinical trial, after this initial step of the protocol was applied, we would identify the probability of severity or the level of that case. So after this initial anamnesis, 47% of the patients were possibly not contaminated with COVID, 29% probably had regular flu, 12% had a suspicion case of severe respiratory syndrome. So 1 out of 10 people going to drugstores had symptoms that were severe, that needed a quick referral. And these anamnesis tool was very important to help us identify how severe the case was. And of course, after the test, we were able to send these patients to receive the proper medical treatment. Still looking at the symptoms and the disease profile, it was interesting to notice that, of course, according to the protocol coming from the Ministry of Health and the anamnesis that pharmacists conducted, we had coughing and shortness of breath as the main symptoms that were related to more severe cases or a suspected case of severe respiratory syndrome that were present in 77% or 54% of patients, depending on the symptom, which differentiated this group of patients with patients that were only with a suspicious case of a regular flu. Once this initial anamnesis was conducted, pharmacist was now confident to indicate an antigen test or an antibody test. And the antigen test represented 85% of the total tests that were conducted. And remember, I'm looking only to data from January to June this year. And looking at the positive cases, we have 32.3%. So 1 out of 3 tests were positive in that period. And that's for antibody tests. And for antigen tests, 1 out of every 4 tests were positive, if you look from the period from January to June. So looking at this year specifically, let's remember that we are talking about a predominance of infections caused by the Delta variant. And patients that tested positive with an antigen test conducted in the drugstore, 10% were completely asymptomatic, which in this sample represents hundreds of thousands of people. So we did have people that didn't have any symptoms, but that were tested for some reason and ended up testing positive. Moving forward in the same analysis, if we compare different age groups, let's look at the age groups with the highest prevalence of positive tests for antigen tests. First, elderly, 34.5%. After that, adults between 40 and 59 with 31%. And surprisingly, in third place, adolescents. After that, adults, young adults between 18 and 39 with a slightly lower rate of positivity than adolescents, and then children with only 20% of positive tests. Now looking in more details at the data, we were able to compare the symptoms that and the prevalence of such symptoms depending on the result of the test. After the anamnesis, after the antigen test, I was able to compare positive patients and negative patients and their symptoms in order to try to identify the differences in the clinical manifestation of the disease for those that tested positive for SARS-CoV-2. And it's interesting to notice that fever or loss of the sense of smell and taste, even though these are symptoms that characterize the disease according to the literature, they were not so prevalent. Even among patients that were negative of positive, but even among positive patients, the presence of such symptoms was around 10%, so 1 out of every 10 patients. While the most common symptoms and the most difficult symptoms to really differentiate cases of COVID from common flu, like cough, a runny nose, a sore throat, and a headache, were present both in positive and negative patients, but of course, with a higher prevalence for positive patients. So a more intense clinical manifestation of the systems for the patients that tested positive. So when we look at this graph, it becomes clear how important tests are. Even using an algorithm to try to identify the suspected cases without a test to confirm the diagnosis, it's very difficult to identify the disease just based on clinical symptoms, because most likely you will make a lot of mistakes to establish a diagnosis if the patient is positive or negative, or even if you are trying to differentiate more severe to lighter cases. And now, approaching the end of my presentation, I just want to highlight that what used to be unimaginable, thinking about drugstores as a new point of care with clinical characteristics, and using the huge spread of our footprint in the country, and the implementation of a highly complex protocol, the training process that was required, all the quality assurance measures, the use of a standard result report, and using the health surveillance services from all municipalities. Despite of all these barriers, what we had was drugstores working pretty well as these point of care with their open doors, providing the services to millions of people. And these pictures tell the story. They tell the story of this moment of Brazil, which is also an important moment for drugstores. Really remote areas in Brazil where many times we didn't have access. We had pharmacists on boats and traveling to people's homes, pharmacies and drugstores serving as pillars for these communities, and as a place where people were able to find information, a quick test, and the appropriate referral to other services, which contribute to eliminate some of the pressure that was put in the local health systems from all the patients that were looking for these services with symptoms of COVID-19.
So this shows that this program is a reality. We have been working on this area of pharmaceutical assistance for a long time now, and we can see that the COVID test is only the tip of the iceberg of what drugstores are able to do within the healthcare sector. So whether it's regarding adhesion of treatment, self-care, telehealth, quick tests, not only for COVID-19, but other, quick tests that are already conducted in drugstores. There is, regulatory barriers, but we have many tests being conducted in pharmacies, and of course, vaccines. I'm not going to go deep into vaccines, but pharmacies already offer vaccines since 2017. And regarding the pandemic, they could offer their capacity and their facilities to conduct vaccination. Thank you so much again. Thank you so much for having me, and I'm available for questions. Thanks again. Thank you, Cassiano. Stay with us because we will have a Q&A session with all other speakers at the end of the panel. So now I would like to invite Pablo Moreira. We are going to change a little bit the subject. This is a panel about new technologies and new health environment. So we're going to talk about other experiences other than COVID. So now I would like to invite Pablo to give his talk. All right, Pablo, so again, you have 15 minutes. The floor is yours. Thank you so much. Thanks for having me. My name is Pablo Maciel. I'm a pharmacist. I work in the healthcare in Victoria da Conquista. I'm conducting my master's in public health, and I'm going to talk about hemoglobin testing in the healthcare sector. I'm not sure if you're in presentation mode yet, Pablo.
Tá? Não tá mesmo.
No meu computador.
No, not yet.
Deixa eu só.
Vê se você consegue. Agora sim, agora sim.
Yes, now we have it. No, just 1 second, please.
Tá aparecendo aí?
Can you see my presentation?
Não. Você cancelou a apresentação.
Not yet.
Agora sim.
Tá com algum problema na hora de transmitir.
Acho que você mandou a apresentação?
Não, não mandei. Tá no meu computador.
Agora sim.
Foi? Pronto.
I'm
Não
presenting directly from my computer, and now we're good to go, I believe. So let's do this. Okay.
Bem, então a gente vai trazer um pouco da experiência do point.
So we're going to talk a little bit about the point of care testing of glycosylated hemoglobin. And I'm going to talk about the experience of Victoria da Conquista. We have about 350,000 inhabitants. We are a reference regarding education and health. We have 2 public universities and other 5 private universities with courses in the health area. We have a good level of organization. We have solid partnerships between the universities and the public healthcare sector. And with that, we are able to work together in teaching, research, and other projects in the city. We also focus on the public district pharmacy, which is also a pharmacy for the Federal University, and we have 4 pharmacists working there with a good clinical education. In 2018, the city had 2 projects with external funding. The project Health Rise, funded by Medtronic, and another program from the public healthcare system of Brazil to focus on chronic diseases. So this was the first point to start testing of hemoglobin A1C. So we knew that we had to work on offering testings to control diabetes, for example. And so we discussed the idea of offering to people
Mas através do método de hemoglobina glicada, né?
this hemoglobin test available for people, which is the GO test both for diagnostics and to monitor diabetes. And we know that how difficult it is for people to have access to laboratory tests due to distance. And so we thought to make this type of test available at the point of care. So why using the point of care at the clinics? We wanted to understand if it was effective and the cost effectiveness of such initiative. So we developed together with our team. We have a partnership between technicians and students from the university, from the pharmacy course of the Federal University of Bahia. And we work together conducting a review study to understand that if investing the resources of the Health Rise project, if that would be cost effective. So we developed a research The goals was to evaluate the cost effectiveness of the point of care A1C tests in comparison to laboratory tests for people living with diabetes type 2. We use the economic model based on Markov, and we wanted to evaluate the cost effectiveness for the city to evaluate if we could bring this technology to the city to monitor people living with diabetes type 2. Thinking about, prevention of cardiovascular complications, amputations, problems with the kidneys, and so on. So we understood that a better control of glycemia levels would reduce the risk of complications, and the control of A1C would reflect in the control of the disease itself. As a result, we were able to understand that the use of the point of care is a cheap alternative to improve access to A1C tests and resulted in an increased rate of early control of glycemia. So we had the funding from two programs, from the Health Rise Project and from our public sector in Brazil. We do not carry any conflicts of interest, and that did not, the funding did not interfere in our routine in the city. So if we have the cost effectiveness of this alternative, how would that work in the community? We had to understand the use of the point of care, and we chose then to observe underserved rural areas. We have a huge city. This is the third largest city in the state of Bahia, and we have rural areas that are almost 100 kilometers away from a laboratory, for example. So we developed the research in these areas, and we wanted to understand if our interventions would be sustainable in the long run. So we trained professional healthcares, especially considering the population with diabetes and hypertension. And so we offer the point of care in 4 communities for A1C tests. So we conducted the before and after tests. We had education interventions, and we also used the results of the A1C tests to help with the interventions in the point of care and other treatments. The study was interrupted. We had prepared 6 months of study, but we had to finish in 5 months because of the pandemic. In 2020, in March, we had to stop our activities, and we have used the results that we had in those 5 previous months. So now we were able to identify that for 17% of the patients, we were able to control diabetes with the point of care, with the use of that equipment, and 38% of those had a reduction of over 1% in their A1C levels. With that, we conducted a third study, also funded by the Health Rise program, and we wanted to understand if there was a way to apply the use of A1C tests and other points of care, both in rural and urban areas, or areas with difficult access, communities in the cities that were away from laboratories or healthcare centers. So we wanted to understand if the use of the point of care device was feasible. So the goals of this test was to evaluate the application of the point of care technology to estimate A1C in the glycemia control. We have evaluated a database from 2018 to 2020. So we had different initiatives conducted by the Secretary of Health. And for those who had not recent tests, we made those tests available through the point of care devices. If other people had a suspicion of a change in their level of glycemia, or they had a history in the family, we also made those tests available. As a result, these patients, from 143 patients that did not have tests, they performed the test and they had levels above 7 or 8% if they were adults or seniors. So we were able to identify that the use of the device improved the access to the test for people who live in underserved areas. And we were able to increase the level of diagnostics to identify patients with under-controlled glycemia. With that, we improved other discussions internally. So for example, if we make point-of-care devices available at basic health clinics where people come back after 2 months to control their glycemia levels, for example, is that an effective initiative to help with the glycemia control of those patients? If we offer quick tests, we can decrease the lines of, appointments, health appointments. And if the patient is already controlled with that type of intervention, so then we started at the pharmacy. We took a part of those patients from our service. So these are patients that have diabetes. They use insulin regularly, and they use the capillary glycemia equipment. So they come back to the pharmacy regularly. We have dosed their AC1 in the pharmacy. We serve all of them. And within the appointments, for those who had not a test, we made the tests available.
And what are the results we have had so far? So overall, we assessed capillary glycemia as well as HbA1c. And when we have a patient, and here I'm talking about patients with postprandial glycememia, we are able to have 21% with glycemia lower than 180 among 180 and 250, 30% of patients, and above 250, 42%, which indicates a level. When we assessed HbA1c, we noticed that out of them, 33% had an HbA1c level lower than 8, 36% between 8 and 10, and 31% of the population in the study initially in this first appointment had an HbA1c level above 10. So 1 out of every 3 patients we saw in our drugstores that are on insulin do not have their diabetes under control. With this data, we can demonstrate that HbA1c in the point of care allows us to have a fast assessment of patients. We can identify patients that are not controlling their glycemia, and we can refer them to non-pharmacological interventions that are conducted here, but we can help adjust their insulin dose. So if we think that 1/3 of the population doesn't have their glycemia under control, we should also discuss that if HbA1c should be the gold standard for monitoring the patients. Maybe we can have a protocol that use pharmacists and the healthcare professionals so we can make interventions that are more effective to control diabetes of these patients. These are the preliminary results. We will continue to see these patients in 3, 6, 9, and 12 months, and we will assess the HbA1c results from these patients and the behavior of these tests. This will be the next step of our process. But what are the challenges that we have identified for the process? Dr. Cassiano already mentioned the challenge regarding regulation. I think Brazil needed to move forward so we would have the legal safety to conduct investments on point-of-care tests for A1C and for other parameters. For primary care, we need to ensure we have the right resources to acquire the different materials we need connected to HbA1c, but in the first semester of 2022, we will include a lipidic profile, and we are considering the possibility of including other tests that are important to assess, especially the effectiveness of the drug treatment, the drug that is collected here in our drugstore. And we have to think about point-of-care tests in combination with the different lines of care, especially for chronic disease like hypertension, diabetes, and cardiovascular diseases. So the technology that is offered is not only a result, oh, your HbA1c is at this level, but what is going to happen after the result of a fast test so they can truly gain control of their disease and gain more quality of life. And we also need to discuss the awareness of health professionals. There's still a long discussion about the quality of these results. In our case, before we start our activities here in the rural areas and in our drugstores, we did an internal assessment of the device that we use. We use an Abbott device for this purpose, but we chose to use two pieces of device. We started with one from Roche. Today we use one from Abbott, but we also need to understand that when we are making the investment, what are the internal evaluations that these devices have? We did an internal validation as well of this process, but we also need to raise awareness among professionals, especially the ones that left college longer. It's important for them to understand that these results are comparable to results coming from a lab. The great difference when it comes to point-of-care tests is the fact that we get an immediate result and patients can leave that appointment with all the necessary recommendations without the need for patients to go to the lab, which takes more time, it's more costly. And when it comes to the public health system, it crowds the service. Our perspectives for the city for 2022 is to maintain the use of point-of-care tests for HbA1c. We are currently acquiring new tests, and in 2022, we will include a lipidic panel as well. And we will work on the results depending on what we find in our assessments. Maybe we will include a higher number of drugstores and pharmacists so they can use the technology to ensure the treatment is being properly conducted so these people can have more quality of life, reduce the level of complications, and they generate fewer costs to the health services. This is my contact information and I'm available if you have questions. Thank you. This has been a great talk. I hope we have time to talk about it in the end. Now, I would like to invite Dr. Leon to talk about his experience in the use of point-of-care tests. It's a pleasure. Thank you for the invitation. Maybe we can show my presentation.
Ok, perfecto. Bueno, vamos a conversar ahora un poco la experiencia que hemos tenido en el Perú haciendo investigación respecto a pruebas rápidas para COVID.
Let's talk about the experience we have had when it comes to fat tests, rapid tests, and the perspective of COVID-19 in terms of diagnosis. Next one, please. We have a problem. And the problem we have, and it's not a medical problem. And the biomedical approach we have in the beginning of the pandemic, this became a problem that is beyond of what we had imagined initially. We are no longer talking about the SARS-CoV-2 infection, but a problem that is a social problem, one of the largest problems we have had in the history of mankind. Next one, please. For us, working in labs, so we can explain to other professionals what diagnosis depends on. We have a number of tools that we can base our diagnosis. We have molecular tests, and many countries based their lab diagnosis for this infection, for COVID-19, in serological tests, antigen tests. And this was a mistake because we had a results weeks after the person had been infected. So moving to a molecular test was a difficult step for many reasons, especially because the world didn't have these tests available. So little by little, they started to see this and implement this with the help of centers to control the diseases in China, the OMS, and other countries started to use molecular tests. The antigen test was a good evolution. We heard a lot about this today, and it became an important tool for us that don't have such difficulty in implementation, but especially the problems that countries were not ready for that. They were not ready to use molecular tests in an efficient way. So if you look at the global scenario, where was the largest amount of tests coming from? We can realize that almost 50% of the tests were coming from Asia. Some were manufactured in other regions of the world, but Asia was the main supplier of these tests. In that sense, many of the tests that were being marketed and that are still available are serological tests. And then we started with molecular tests. They started to grow in the different countries. Countries started to have more access to them because they had molecular laboratories inside universities and private and public health systems. However, that was not a reality and still not is in some countries that centralized their molecular testing to detect COVID-19 cases. So if we look at what happened in Peru up until a few days ago, and we have an open data policy, we processed a lot of rapid tests. In the beginning, Peru was one of the countries that used the most rapid tests, especially serological tests that were bought in high quantity in the country, especially in Lima, where 30% of the Peruvian population lives. Lima was the city with the highest presence of these tests. So there was a level of positivity that was around 11%. So in terms of expenses, the fact that we acquired these lab tests that before the pandemic was not part of the budget, up until the moment they represented 300 million Peruvian soles. This is what it is important to see these numbers in the official government webpage, because these resources represented 30% of the tests. And 30% was for fast or rapid tests. It's not that when we look at the details, they are not represented here on the slide, but the highest investment was made to acquire rapid serological tests. But when we see that serological tests that were acquired, especially recently, with are related to companies that distribute devices, probably 30% of these expenses is focused on those type of tests, and other 30% to open technology tests that were more centralized when it comes to the work of the Ministry of Health. So during the pandemic, and that was a reality for many countries, we had a need, and we still do, not just in Peru, but many countries, which is the need to have a fast diagnosis, because patients need that. And this is a very important point. We are talking about a respiratory infection. What we do not want is for patients to go to the hospitals. And this is what happened in many places. And tests, they need to be easy to be interpreted when patients need it. And with materials that are easily accessible and easily used. And we need that fast implementation at all levels, but it's important for them to have the highest standards of safety with very little training required, so everyone can use them. So if we look at lab diagnosis, in the past 2 years, we were able to see that this was actually information that we already knew, but the population wasn't aware of, which is the fact that an effective diagnosis was basically the eyes and ears of our global response to the pandemic. So without a diagnosis, it's almost like we are blind and deaf in the face of an event that is affecting the whole planet. This graph shows us what happened in Peru in the past few months. And this was the scenario regarding the number of tests that were authorized by our regulatory agency. Let's wait a minute. We have a technical problem. We'll make a quick break and we will be right back.
Ok, estamos de vuelta. Uno de los traductores es más adicto que yo al café y tenía que ir por su cafecito. Bien, les estaba diciendo que en el Perú,
Okay, so we're back. So in Peru, during the pandemic, the agency regulating medications also authorized 700 laboratory tests. When we see this table here, of all those tests, 617 were IgM and IgG tests, antibody tests. This is the official information for PCR tests. So the largest amount of tests actually was authorized for serological tests, and we understood that does not solve the problem of isolation, which is a very important piece of information so that more people do not get contaminated. These results come from molecular tests. We were then trying to find out a solution. One of the things that we wanted to see was the idea to break the centralization regarding laboratory tests. They are conducted in large laboratories with a lot of requirements, very skilled people, and with high levels of quality. So the idea was to move out of the scenario without losing quality and transferring the laboratory tests to the places where patients were. With that, we evaluated a test, a real-time PCR test that takes about 45 minutes between sampling and having the results. So there was a reduced workflow, and this is something that can be used with the patient and detects both genes RDRP and N, which are the regular tests that were being conducted throughout the country. This new validated technology is a biochip technology. It allows us to process 4 samples in one run, each one taking 45 minutes, which has negative and positive controls included. So you get 10 microliters and mix it with the fluids inserted with the chip. That is amplified within a very small device, and this provides you a real-time PCR result in 45 minutes. So this clinical validation is basically conducted through a process of implementation. So Viral Lab provided us the reagents and the technology. So this product came from Korea. At our university, we started to develop protocols, training of the staff, and the integrated staff, or the staff was made out of several physicians, the physicians that are on our screen now. And so we conducted several actions to guarantee the training. So the idea was to train the staff to collect samples and also to process the tests of those patients, symptomatic patients that already were at the emergency area of the hospital. So training took about 1 week, And at the hospital, we had a sort of a booth. But that type of equipment could be used out of the booth. So everything happens inside the device, really. So we were able to evaluate 64 patients, symptomatic patients who were sick, presented fever, cough, all the symptoms related to COVID-19, and who showed up at the ER. We used duplicate swabs. One was sent to the hospital, the other to a reference lab. Everything was conducted from August to November 2020. So we worked together with the pathology lab from the hospital. One of the important results that we had is that we found a very high sensibility, 100%, 98%, and it works both when the person has symptoms and while the patient is waiting for the results. I can isolate without having to move home or an isolation place. In general, what we've seen is that there were several tests available. We have seen over 700 tests, but not all of them were useful for the pandemic. One of the things that we really need is that the implementation of tests is conducted with more agility, and we need a trained staff. The tests are important, but they have to move from hospitals and ERs and go to local clinics. And what we've learned is the collaboration between university and other areas. This is very important. I would like to thank my whole team of research. Thank you so much. So, Professor Cesar Cano, the floor is yours, and you have 15 minutes.
Bien. Buenas tardes, ¿me escuchan?
Boa tarde, escutamos.
¿Qué tal? Buenas
Good
tardes.
afternoon. First of all, I would like to thank you for having me. I'm Cesar Cano Candiotti. I'm a doctor specialist in occupational health. I'm the vice president of the Peruvian Society of Occupational Health, and it's an honor to be here. First of all, this is my conflict of interest.
Y el tema que les traigo es un poco para poder conversar y compartir la experiencia del uso.
So now we are going to talk about the experience of use of these point-of-care tests in work settings. So I would like to remind you that what is the importance of occupational health? So we're going to focus on two fundamental rights that sometimes in the medical school you only talk about health, how to reach the highest level of health, but that's not the same at work. We focus on these two rights. It's no surprise that if I'm healthy, I have a ability to work. And if I have good work, I have access to a good healthcare system. What does that mean? With the pandemic, we've seen that several diseases related to work are responsible for 25% of the load. We have 2.78 million deaths per year related to work. And so this is very important. In 2019, 2019 was a very important year for us. We had a report from the future of work, and this is a picture showing an automated process. There is no employee here, and this is no science fiction movie. So we were talking about virtualization of work, technology of information technology, and artificial intelligence who would replace the workforce. We were also talking about demography, sustainable development, the impact of climate change, and the changes happening in the workplace. This is a report from 28th of April 2019. And in 2020, we've seen the first cases of COVID. So we had a group of employees that were going home for quarantine. And so we had to start working from home. But there was a group of essential workers that had to keep on going to work. So there were strict measures so that they could still keep on working. So our objectives is to review the principles of vigilance of health, surveillance of health of workers, and the impact of the use of point-of-care tests. So there are some figures here. We've had 266 million people infected. 50% of the workforce of the world, and it's the same in Peru. So we have 2,243,000 infected. So our approach to the workforce is very important. So how did COVID affect the workforce? Let's focus on 4 points. So let's talk about the conditions of work. We've had the healthcare workers who were most affected. There were the risks regarding biologic control, psychosocial risks, how to perform surveillance, and the impact on productivity. We've had an increase on the absence. We've had the costs of hospitalization that could reach up to 15 days, sometimes a month if the patients were placed in a intensive care unit. So we've seen that regarding COVID-19, this is a highly transmissible virus. The detection of the virus takes about 1 to 3 days. There is a high percentage of 40 to 50% of asymptomatic cases that still spread the virus. Why is this important for the work environment? When we look at work environment, we have to reduce the transmission in the workplace, because asymptomatic people, as we've seen from reports, we've seen that COVID-19 pandemic is not the first pandemic we've faced. We've seen the H1N1, and the WHO had already stipulated the phases of work. So mitigation, contention, monitoring, all of it was related. So we had epidemiologic monitoring, education and communication control measures, supply chain, and the epidemiologic surveillance in the workplace. I would like also to talk about the measures implemented, not only in in the workplace, but also in communities to reduce transmission of the SARS-CoV-2, which is the Swiss cheese respiratory virus defense. It's a very simple model. Each slice may pose a failure in the process towards the objective. So to reduce an event, we would have to work on each slices of the cheese. And so the idea is not only a measure to reduce the transmission, it has not to do only with tests and hand hygiene, but everything altogether.
So the different areas of intervention that we have has to do with the working conditions, health surveillance, focused on the health condition of workers, individually and collective. We do emergency service in some places, and we do intervention in communities and the promotion of health. And let's remember that because of the pandemic, we also identified that not all workers were affected in the same way. There was a group of workers that were at a higher risk, who suffered from chronic disease, and they were more effective from the pandemic. And we see in the different work environments also workers that are not symptomatic. So we did an active search for cases with a focus on early detective. Of course, we made sure we were using high specificity tests that were not invasive and that provided with a fast result. So once we are aware of all those characteristics, we saw that the point of care testing are very important for our study. Here from Dr. Castaño, a study on POCTs from the past few years. These are tests that started in the 1980s or 90s, so they're nothing new. But of course, during the pandemic, they became an opportunity. And they talk about 5 levels in this study. A self-test, the community level. They talk about low complexity medical centers, labs, and hospitals. And in the work environment, we can be in levels 1, 2, or 3, depending on the type of project we have in place. And how is the implementation of the point of care tests in the work environment? We had already mentioned that we do health surveillance with an active search, especially the search of certain infections like tuberculosis, HIV, influenza, and we also use this test for biological control, for toxicological dosage, with markers and urine tests. These are tests that we use for health surveillance work in the work environment and for urgency or emergency treatment as well. We want to have tests for glucose and urine, but these tests can also be used for the promotion of health. And of course, that depends on the context of the project. Some, for example, for the mining context, in remote areas, these are projects that require us to reach workers through a helicopter, and any unusual event require us to make a fast decision. So to make these type of decisions, we need these tests that will assist us in the process. And how did we implement epidemiological surveillance in the work environment? Talking about that 4 steps that I mentioned before, the planning, mitigation, containment, and recovery. We'd say that these patients, they would go directly to the health system. And what we did was to track all the different contacts that they have, the cases, and the ones that are diagnosed. These cases are interesting because we need to reincorporate those workers in the workforce. But what we do is to do a health surveillance work in the non-symptomatic patients. And to manage symptomatic patients, we need to identify the community load, which is essential. Many of the studies that we conduct, we focus on identifying how effective these tests are for symptomatic patients, but that work is not done for non-symptomatic patients. That's why it can be confusing in selecting the right test. We do just a triage. We don't do a diagnosis when we do health surveillance in the work environment. We use other epidemiological tools, like, for example, some companies, some mining companies, we would do a project for 15 days, and when they came back, we would see if there were any problems. Epidemiological indicators were essential. These are the key metrics that we used regarding new cases for every 100,000 inhabitants. And how were these tests used in the work environment? I'm not going to go into details about the detection methods, but basically we have three types, basically. We can use genetic material, we can use an antigen test, and we can use an antibody test that are generated after a previous exposure, as it has been described here. This was an option that was used in the beginning, but it didn't make sense because we know that serological tests, they identify a case only in the second week, and our concern in the work environment is transmission. So when we look at the behavior of the tests regarding the natural history of COVID, we have the onset of symptoms, but one of the characteristics of this virus is that it can be transmitted 1 to 3 days prior to the onset of symptoms. So at this stage, workers are not symptomatic, and in the worst case scenario, symptoms only appear later. So we see the viral load here. We start that rising before the symptoms, and it goes down up until day 7. The PCR tests do very well in this context. And these levels can stay high after 10 or 14 days. So we can find remaining parts of the virus. And for us, that was also important because some workers would spend 14, 15 days and would still test positive on a PCR test. So we worked with RCT to identify those people. And the serological test, we see this increase after week number 2. This is an important chart because we see that symptomatic patients, they do spread the disease, but in a lower period of time, shorter period of time, sorry. So it's important to identify them earlier on so we can conduct the treatment appropriately. This is what I said before, the studies that we had on sensibility and specificity with a higher focus on symptomatic patients, which are quite established now, but very few studies for non-symptomatic patients. This is the algorithm that we used for conducting antigen tests in non-symptomatic patients, and the confirmation with an acid amplification test. This is the final review from the American College of Medicine, and they proposed a control framework through antigen testing. But let's remember, antigen tests alone are not enough. They need to be part of an epidemiological surveillance program. And this is the key message here. This is a study with a sample of around 3,400 people, and they are correlated to the specificity and sensibility of symptomatic patients in the PCR tests, and specificity for 100%, sensibility of 64%, and for non-symptomatic patients, the sensibility is 35.8 and specificity 99.8. But there is a good positive correlation with a CT lower than 25, which allows us to easily identify patients that are transmitting the disease. But when we do a viral sample, the asymptomatic sensibility can reach 78%, and the symptomatic sensibility can reach 92%, which brings us an advantage in identifying this group that is spreading the disease. So we created this program using an antigen test, but trying to control the variables and especially the epidemiological indicators, how to collect the sample, how to interpret the results. And definitely, tests are not for all workers. We use a technique to identify the different group of workers that will receive the test. The test will be conducted in patients that have a higher risk of exposures, patients that travel, patients that are working in crowded places, and workers that have a special health condition that could cause a complication. And interpretation is important. Let's remember that the community load is important. And in a high epidemiological setting, if the antigen result is positive for a symptomatic population, this can change as epidemiological indicators go down. So the use of tests need to be done within a context. Some studies use these indicators, and the same program includes self-diagnosis, diagnostic tests, as previously discussed. These are tests that are part of a program. So workers, they do the tests themselves, they notify someone, and they do a preventive isolation or an early isolation so the virus doesn't spread. And within a vaccination context, we have to remember that even after 2 vaccine doses, we cannot make sure that that person won't be infected. We decrease the level of mortality and the level of severe cases. But this is a key message. We see that happening in Peru. Vaccines are not the only measure we need to take. There are studies on the value, the predictive value of contamination happening after the vaccine, because that depends on everyone's individual immunological response. So how can we use this type of tests for an epidemiological surveillance work for asymptomatic, symptomatic patients and patients with a diagnosis? Now, some final conclusions. These tests, they should be used within a context of medical criteria and epidemiological surveillance. The tests by themselves don't tell us much. We need to have them in context. A negative test does not eliminate the fact of that patient being contaminated or not. And tests alone are not enough to prevent contamination. Some messages on epidemiological surveillance, labor triage, interpretation. And this is part of the references I have used. And I would like to leave you with this nice picture. And thank you for the invitation and have a great remaining of the event. Thank you very much.
Olá.
Hello.
Estamos prontos. Está ouvindo? Elliot, você ouve a gente?
Yes, just.
Ok.
Let me see. There we go.
Okay.
Good. Thank you, and thank you for the opportunity to speak to you today. Also, thank you to the translators who are making it possible for me to speak in English. Just a brief bit of background on me. I had a 20-year career at the US FDA, regulating diagnostics, in vitro diagnostics, and I retired about 8.5 years ago, and now I'm doing consulting work. helping companies and developers move their products through primarily the FDA. What I'm going to talk about is very complementary to Marcela's talk from Anvisa. I'm going to give a talk having to do with the FDA, though, and the impact of the pandemic on the FDA and FDA's response to that. So this is what I'm planning on covering. I'm going to talk to you about emergency use authorizations and how they function as a way to provide access to innovative diagnostics during a public health emergency. I'm going to talk to you about some of the realities that have come about that need to be dealt with. There is long-lasting, I think, there are long-lasting implications for the future of IVD regulation, certainly in the US, and I would imagine elsewhere as well. I'll touch on that. And then talk just a short time about how innovative technologies will get noticed by the FDA, since that is indeed the theme for this particular section of the meeting. First of all, EUA, emergency use authorizations. What it's not a permanent marking authorization, but rather it's a streamlined regulatory approach to make new and essential products, medical products, available during a public health emergency. Now, when I use the word streamlined, that has two implications. Number one, the studies that need to be performed to support emergency use are going to be much more limited compared to a permanent marketing authorization. And also the quality management system that's in place. There are limitations on that. So a full quality management system is not actually necessary, which is different from the way the WHO has handled the test for the pandemic, as well as some other countries. So there are just some specific elements that need to be in place, not a full quality management system. So let me take you through the process for a moment here. It begins with the declaration of a public health emergency by the Secretary of Health and Human Services, equivalent to the Minister of Health in most countries. A company would then put together what's called a pre-EUA submission, which is an opportunity for FDA and the manufacturer, test developer, to interact and come up with some mutually acceptable ways to move forward. That leads to the full EUA submission, which FDA then reviews. There's more interaction, and the goal is an emergency use authorization, such that the product can be marketed while the emergency is in place. The idea is that FDA can, because of the limitations on the submission, FDA can respond in days or weeks instead of months. I will tell you right now, something I'm going to talk about in a few minutes, is that this is the ideal, and it was the way that it took place at the beginning of the pandemic, and things have, shall we say, changed dramatically. I will show you what I mean by that in just a few minutes. But first, let me talk about how FDA has communicated and streamlined a little bit more about streamlining the process. So one of the main things that FDA did was they put together templates for emergency use authorizations. And these templates had in them exact wording that FDA wanted to see in such things as the intended use, and in terms of describing what the product is and how it works and that sort of thing. So it was a matter of the sponsor filling in the blanks in this template. I'm just showing you a template from the first paragraph. Obviously, it's much more extensive than this. It also explained in great detail what types of studies are needed, or what types of studies FDA expects for an emergency use authorization in terms of the analytical studies, and that includes limit of detection. It includes inclusivity studies to show that all of the then circulating strains of the virus are detected, and also included details on the clinical performance studies that are needed. There are a number of these templates. Most recently, they were updated on November the 9th, so just about a month ago. I'm showing you here the template for developers of home use tests. There are other templates available for antigen tests for professional use and for serial testing and screening claims, for molecular tests and molecular home specimen collection devices in which the specimen is collected by the individual and then sent to a laboratory for testing. The studies that are done need to make, clinical studies that are done need to make use of people who, of users who are expected, the intended users who will be expected to use the test. So for example, home use tests need to be supported by data, which shows that people, and ordinary people who would just purchase this from a pharmacy or wherever, would be able to use this test and to show what the expected performance would be by those users. There are many tests that are available, which are for use by professional laboratories, but there are other tests as well that are authorized for use in a point of care setting. And so again, all the studies that are done need to have be done using the intended users to get an idea of what the expected performance is going to be. Just one word about serial testing that I have here. What that means is when you go to purchase a test, you would test, it includes 2 swabs. So you would test once and then wait a couple of days, 2 to 3 days, and test yourself again if the first test was negative. And then FDA allowed performance to be based on that second test. So if it missed the first time and identified as a positive specimen the second time, then the comparator test or the reference test, which is a PCR test, was positive on the first go around. Then the second result for the antigen test could be used to increase the expected performance. A little bit more on transparency. FDA has had a number of, at first they were weekly virtual town hall meetings, and it was open to anyone around the world to call in, but now it's actually web-based. So that FDA could not only share its latest thinking, but also it gave the opportunity, or gives the opportunity, for people to ask questions of the FDA and to get answers on the spot. They also established a mailbox, which is referred to as the templates email address. I show that here. And on several of the slides, I have some links that you can follow if you like for more information on any of the topics that I'm going to be discussing. So the templates email address can be used for general questions so that FDA can clarify its thinking on particular subjects. There have been about 70 or 80, I believe, virtual town hall meetings. They're now down to every couple of weeks instead of every week, but they've been important in having FDA explain its thinking on various topics related to the pandemic. So where are we now? As of last week, FDA has given an emergency use authorization of 423 tests altogether, tests and sample devices. 293 of those are molecular tests and sample collection devices for them. 66 of those can be used with home collected samples. There is one molecular prescription at-home test. So a physician or a healthcare provider would order the test, and that means you could purchase it through that prescription. But there are also 3 over-the-counter molecular tests, as well as 11 over-the-counter antigen tests. By over-the-counter, I mean anyone can purchase it from wherever it is being sold. There is no restriction. There are 90 tests for antibodies, and let's see, and I talked about serial screening. There are 20 antigen tests and 9 molecular tests that are intended for use in serial screening. I'm sorry, 40 antigen tests altogether that have been authorized. FDA has recently, as of just a couple of weeks ago, revised its policy for testing for COVID tests. And in this document, it talks about its current priorities. And the whole theme around this is increased access. So FDA became overwhelmed by the number of submissions it received, and it wasn't possible for them to give every submission a full review. So what it did was it said what was needed, what type of test they would pay attention to, basically, and that is any test that increases access. So that would be home use testing, self-testing. That would also include point of care tests. And also, their FDA for the first time had talked about capacity for manufacturing, so that they're expecting that a test be able to be manufactured at a rate of 500,000 tests per week or 2 million tests per month. If a test falls short of that, or if a manufacturer can't support that, then they won't receive priority review, and unlikely that they will get to move through the system. So it's worth reading this this guidance document. And but again, the theme here is trying to make testing available to as many people as possible. So now let me talk about some challenges to the regulatory process. Something I just mentioned is there was a backlog. That backlog was at one time up to 3,000 applications that were sitting at the agency that were waiting to be reviewed. And FDA's response to that was to bring in all of its review staff from divisions that didn't ordinarily look at infectious disease diagnostics. Rather, you had, of course, the main group, the infectious disease group, took the brunt of this. But different divisions such as immunology tests and chemistry, the chemistry folks were all brought in to start reviewing the COVID tests. And so it was impossible to keep up. But so they did hire another 40 reviewers. The problem was that reviewers don't become reviewers immediately. It takes time. It takes some work to develop a sense for what is appropriate in a regulatory sense. So, but at the same time, FDA was faced with inconsistency among the reviewers. Some were too stringent, some were not stringent enough, and so there was this inconsistency within FDA's reviewing. The other piece was that with everyone working on this at the FDA, they were working literally 7 days a week and 16 to 20 hours a day just to try to work their way through this. And as a result, there were a number of veteran reviewers at the FDA who ended up retiring because it was just too much for them to handle. So there were new reviewers were hired, but at the same time, there was a loss of veteran reviewers who had that strong sense of what's needed to conduct the review. Antibody tests have been mentioned. FDA is having somewhat of a difficult time with antibody tests. They have authorized some. They will not, they said, authorize at this time, will not authorize antibody tests that are for home use or for self-testing, because it's unclear how much antibody allows you to say that you are protected. Those studies are apparently underway in several laboratories, But FDA does have that concern that someone is going to say, this test is positive for antibodies, therefore I'm protected and I don't have to go through any of the measures that I need to protect myself and others. There have also been a few recalls of authorized products having to do with false positive test results. This affected a couple of tests, and but I think it underlines the speed with which review is taking place and with which manufacturing is taking place as well. Variants. We all know that Omicron is with us, and there are a number of other mutations. FDA has published a guidance, which I'm showing you here, which talks about what manufacturers are expected to do to keep up with this. It was just on Friday, I believe, that FDA published a document which noted that 26 of the molecular tests that have been authorized will miss the virus by one set of primers. Fortunately, there are multiple sets of primers in those tests, and so detection of Omicron would be detected by those tests. But it again underlines the point about having to keep up with mutations and having the manufacturers demonstrate that they're able to detect those new mutations. So, what's the current state of FDA regulation? The reviewers that were brought in originally to help with the caseload, they've returned to their divisions, and of course there were a number of submissions that were waiting for them that companies had turned in before the pandemic hit. And so they are working to address those submissions, but the infectious disease folks are still addressing massive numbers of submissions, even with the added staff. There continue to be 160 new submissions every month. So it's been very challenging for them. As a result, FDA has said they will not accept any pre-submission meetings for a test which doesn't have to do with COVID until possibly the second quarter of next year. Pre-submission meetings are important because developers and manufacturers will meet with the agency to get feedback from the agency on studies and other aspects of their device. And then for novel technologies, there are some options, including the Breakthrough Device Program, the Safer Technology Program. And for those, it's very important for manufacturers to focus on the benefits and the risks of new technologies. And just on the subject of new technologies, it's been interesting because we've seen a dramatic increase in the number of new companies, usually spin-offs from academic institutions, who are developing tests using very interesting technologies such as CRISPR, and trying to get them through the EUA process. But that's also created some issues because the folks in the startups coming out of academia don't quite understand all the controls that still need to be in place for clinical use. There is a program called the Rapid Acceleration of Diagnostics program, or RADx, that you may have heard of. RADx will basically take promising new technologies and work with these companies to fund the studies, as well as interact with the FDA to move them through the regulatory the development and regulatory process. And I show you here a link to that if you're interested. And then last slide is the impact on FDA IVD regulation in general going forward. So I have a lot of question marks here because nothing's definite, of course. But in terms of what's coming sooner rather than later, we can certainly expect that continued delays as FDA tries to catch up on previous regulatory submissions or move other submissions through the process in the case of the infectious disease diagnostic people. Some things that will happen, I think, later rather than sooner. It's possible there will be a more efficient regulatory review process coming, just because that's been demonstrated. The effectiveness of templates, so that concept may be applied more frequently, and that will help with test developers and manufacturers. And then, of course, FDA may be more accepting of over-the-counter tests or self-tests. This is it's interesting that they moved to self-test, and there's a lot of pressure politically for them to do that. But up until now, the only test that has been approved for self-testing since 2012 has been the HIV over-the-counter test. So now, as I mentioned, there are a number of over-the-counter tests available for COVID. And then there's also the hope, of course, that the experience that FDA has had as a result of this will have them be better prepared for whatever is coming next in the way of an infectious disease. So I think that is all I have. Thank you very much for your attention, and looking forward to the question and answer period. Thank you.
Obrigada. A gente vai dar continuidade.
Thank you very much. We will continue now, invite our next speaker, and in the end, we will open for questions. So now I would like to invite Dr. José Alonso from the Ministry of Health of Brazil. And we're going to change gears a little bit and talk about an important response that Brazil has given to the HIV pandemic. Thank you very much, Flavia. Thank you, Aladiv, for the invitation and for the opportunity to share a little bit of the work we do. Just 1 minute before I share my presentation.
Vocês conseguem ver minha apresentação?
Can you see my presentation? We see it, but it's not on presentation mode.
Vocês conseguem ver minha apresentação?
Sim, mas ela não está.
We see it, but it's not in presentation mode.
Agora sim.
Now it's working.
Então, de novo, muito obrigado.
So, again, thank you for the invitation, and I'm going to talk briefly about the challenges that Brazil has faced regarding diagnostic issues in the search of reaching our 90-90-90 goals. I'll share some of the Brazil data. First of all, I would like to talk about... I cannot move my slides. Oh, there it is. First, I would like to talk briefly about the history of DCCI, which is the department where I work at. And this timeline is similar to the HIV timeline. So in 1982, which was the year of the first official AIDS diagnosis in Brazil, and then in 1985, HIV was discovered by Montagnier and et al. And we already had the first HIV test available. So in 1982, but in Brazil, but in Europe and in the United States, there had been previous cases, and we can compare that to the current pandemic, how long it took before we got our first commercial anti-COVID test and the time it took to have our first HIV test. Just as a side note on how technology have allowed us to move much faster today. And then in 1986, the National Program for STDs and AIDS were created from the Ministry of Health. And after that, we have the history of HIV diagnosis in Brazil. In 1987, we created the first center for diagnosis with an attempt to decentralize this work. In 1988, our public health system was created, and that included health coverage to every Brazilian citizen. In 1990, in 1990, we have the legislation for the National Public Health System.
A gente tem aí em 91, né?
In 1991, after the creation of the public health system, we started the process for the acquisition and the distribution of antiretroviral drugs in Brazil. In 2009, we incorporated this to the program, or actually we included hepatitis, viral hepatitis, in the same department using treating STDs and AIDS. In 2013, we allowed nurses to conduct rapid HIV tests, and we started offering universal antiretroviral therapy for every person with HIV in Brazil. In 2017, we took an important step, which was the first registration or the first authorization for an auto test in Brazil. This became a public policy in Brazil, and today we have the Ministry of Health distributes these auto tests to the population. And in 2019, the STD/AIDS department became part of other departments that focuses on tuberculosis, because tuberculosis has to do with the mortality rate of HIV, so that allowed us to act more effectively. And this new department became the chronic disease departments and sexually transmitted infections. And this department has some priorities. Because if we look at the list of priorities, both the ones that are connected to HIV and other diseases, diagnosis is present in all priorities. So if I want to reduce the mortality of people living with HIV or with a co-infection of tuberculosis, I need an early diagnosis so they can focus on their treatment. So tuberculosis, expansion of access to treatment, expansion to action to prevention. Diagnosis is part of all these actions. So it's important to remember how relevant diagnosis is every time we are taking measurements to fight an infectious disease. And now I want to talk a little bit about the 1990 initiative. It was proposed by UNAIDS in 2014, and it established targets for many countries that were signatory to the pact by 2020. So last year was the final year for countries to assess how close they were in meeting the goals established by the 1990 initiative. This initiative serves as a preparation process for an even more ambitious target, which is the end of the HIV pandemic as a public health problem by 2030. So 1990 doesn't end in 2020. Now we start working with more ambitious targets like 95, 95, 95. I will give you more details on these numbers in a minute. And this initiative included consultations with the policymakers in many countries. And the goal of this initiative is that by 2020, 90% of people living with HIV are aware of their condition, so they have a diagnosis. 90% of people with a diagnosis are receiving treatment, and 90% of people that are receiving treatment are in viral suppression. So in order for us to reach these targets, we need a joint action regarding the different health programs from many countries so we can reach those numbers, because the final goal is to get to viral suppression, because when I get to that point, I reduce my viral load or the viral load that exists in the population, and I can reduce the HIV transmission. And I can more efficiently implement actions that focus on prevention. So for a country to know if... Next slide.
So for a country to monitor its status to actually reach 90-90-90 is an effort to instruct countries to create a cascade of continuous care. So you have to understand that this cascade takes into account several epidemiologic data, data from HIV, data from the assistant of those people living with HIV. And we have 2 documents in Brazil regarding that. So we have the recently launched the epidemiologic bulletin regarding HIV/AIDS of 2021. And we have the HIV clinical monitoring report from 2020. We will have the 2021 available very soon. So we have those 2 documents, one from data from 2021 and the other one from data from 2020. Both are free and available on those hyperlinks. So now I would like to talk a little bit about the figures of HIV in Brazil. So in 2020, just like we can see in the epidemiologic bulletin, we've had 32,701 new cases. If we look at the timeline since the beginning of notified cases, it's 381,793 cases of AIDS in Brazil. We have to make that very clear, because for a long time in Brazil, we were only identifying AIDS cases and not HIV cases. HIV is more recent. So that's why we have these 381,000 notified cases. Up to a certain year, we've had only AIDS cases notified, and just recently we've started to notify HIV cases as well. In 2019, were 43,311 cases, and we've seen a reduction of cases in 2020. We see this as a result of the impact of the pandemic, that due to the social distancing measures at the beginning of the pandemic caused people to isolate. And so healthcare services were not sought after. And we've seen several healthcare professionals moving their attention and their service to deal with COVID. So there was a very important impact of the pandemic. We had attitudes to maintain diagnostics, but this impact is very significant. This is the detection rate. At the beginning, we had national data, and now we have data divided by region. So you're able to see a detection rate by 100,000 inhabitants, and we see a significant decrease from 2019 to 2020 in all Brazilian regions. However, we're also able to see that the mortality coefficient as a good result is also decreasing, and that is a direct result of the distribution of antiretrovirals for those living with HIV. This is an action that had a very positive impact regarding mortality, with a very significant reduction in the mortality rates, and that continues to decrease. During the pandemic, other creative options had to be conducted to distribute medication for people.
Também no campo das boas notícias que a gente pode, que os nossos dados eles
There's
demonstram.
also good news from our data, which is that if we look at children below 5 years of age, we've seen a decrease in new infection cases, and we've had a sharp decrease in 2020. The detection of pregnant women is still high, but this is positive because if we're able to have a prenatal detection, we are able to work on prevention of vertical transmission. So this is a very important piece of information to fight HIV in Brazil. We've seen a very significant decrease in of cases in children below 5.
Também a gente continuando aí sobre a questão do pré-natal, certo? Então,
so here's a chart showing the improvement on diagnostics during prenatal.
Em 10 anos, a gente
in 10 years, we are able to see an increase of 30% from 2010 to 2020 in the detection of HIV in pregnant women. So that is not a bad thing, like I said, because we can implement prevention measures regarding vertical transmission. And this is something positive if we look at a broader picture of fighting HIV in Brazil.
Como eu falei para vocês, a taxa de detecção em gestantes, segundo região, a gente
So this is the detection rate of HIV in pregnant women per region. So we can see an increase of the detection rate, but that is still positive regarding the implementation of prevention measures of vertical transmission.
Também aí a gente olhando, né, especificamente a detecção de AIDS em menores de 5
This
anos.
is the detection rate of AIDS in children below 5 per region. So we see a reduction trend in children below 5.
Sobre a distribuição dos casos de
So
HIV.
this is a chart showing the distribution of cases of HIV and AIDS, considering age and sex. So in Brazil, we have an epidemic that is more prevalent in men. Men account for almost 70% of cases, and women are around 30%. But we also see an important feature in Brazil in 2020. We've seen younger people being affected. So we see that from 20 to 30 years concentrate the largest amount of people infected. And this is very important regarding the pandemic in Brazil, because now we see the need to focus on specific layers of the population to deal with the prevention of HIV/AIDS. So we see that younger people are more vulnerable to the transmission right now. So we have to pay attention to this population. So people from 20 to 34 years of age. But when we think about diagnostics, diagnostics do not happen right away after the infection. So we have to think that people that are 20 might have been infected 2 or 3 years before diagnostics. So we have a very young population getting infected, and we have to really pay attention to this regarding HIV transmission. One other important aspect regarding HIV epidemic is the late diagnosis. So, like I mentioned, people who are 20, 24 might have been infected 2, 3 years before diagnostics, and we can see this in the white cell count in the first exam that they take in the healthcare system. So here is data from 2020. 28% of people who start a treatment in the public healthcare system, they have their white blood cell count below 200. So it's a sign that this infection occurred a little before the diagnostics, and this is something that we have to fight in Brazil, and this is going to be our focus in the future. So what is this population that we're dealing with, people who are living with HIV in Brazil? Today, Brazil lives a concentrated epidemic, so to speak. It's concentrated to certain clusters of the population. This is data from independent studies, some of them conducted by the Ministry of Health. But data show that in general population, the epidemic affects 0.4% of the population. But when we deal with specific groups, we see a high prevalence of HIV infection. Some studies show a prevalence of HIV among men who have sex with men, ranging, and the gay population ranging from 1 to 14%. If we work with the trans population, this is a highly vulnerable population with a high prevalence that can reach up to 36% of prevalence of HIV. And there are other priority populations like sex workers, women who are sex workers, and drug users. So what we can see in this chart is the populations that need to be focused, populations that we call key populations and prioritary populations regarding HIV. So who are those populations? HIV is an infection that affects some people who have certain vulnerabilities. So then we have key populations, which are segments with unproportional prevalences compared to population in general. And we have priority populations, people with vulnerabilities associated to their lifestyle or social, historical, or structural context. So we have to focus on them when we think about fighting HIV infection.
These populations are connected to these vulnerabilities, the vulnerabilities that these people face. So social contexts of discrimination that will affect the service that is provided to these people. Because many times these people don't look for their health services in order to get a diagnosis or to access treatment. So despite that, 45,000 people started for an HIV/AIDS treatment in 2021. And remember what I said about the notification. Even though the number of notification that I previously presented is a reality, from 2012 to 2020, 666,000 people are receiving HIV treatment in Brazil. In 2021, we have 694,000 people receiving treatment, which is highly significant because we need to treat all of them. And we are working with growing rates of distribution of antiretroviral therapies. And like I mentioned before, what helps in the adherence to this antiretroviral treatment is because of the COVID pandemic, in order to ensure that people living with HIV didn't need to go too often to a health clinic to collect their treatment, the Ministry of Health allowed for the antiretroviral treatment to be distributed within 90 days. Before that, people used to collect their drugs up until 60 days, and that was expanded to 90 days, which was a very successful experience. And since the implementation of this measure from 2019 to 2021, we see an increase in the number of people that collect their treatment every 90 days. And we hope to see that number grow as time goes by. We also work to decentralize the diagnostic services because we need to test more people, we need to detect the virus so we can start treatment for more people. Today in Brazil, the average time for starting the treatment is 30 days after a patient accesses a health service. But when patients come to their health services, it's not usually when they're doing their first test. This varies a lot depending on the region of Brazil. But our work is to reduce the time to start the treatment. 30 days is still too long. We need to have an earlier start, and tests have a great impact on that. And as you can see from the 2020 to 2021 numbers, we continue to expand the distribution of tests. And I mentioned all this data to all of you to give you an overview on how we can get to this continuous care cascade. This is the most updated version we have for this in Brazil. With the first set of bars is a number of people with diagnosis of HIV in Brazil. different colors show the historical series from 2012 up until 2020. So the first set of bar talks about people with a diagnosis, the second bar, people that are receiving treatment, and the third set talks about people that have reached viral suppression. They are undetectable. And Brazil was able to surpass the 90% target that have reached viral suppression. Unfortunately, the COVID pandemic had an impact on all diagnostic actions. After a historical trend of growth in the number of cases diagnosed from 2019 to 2020, unfortunately, we saw a drop. And we connect that to the COVID pandemic that had an impact not only in the HIV diagnosis, but in other diseases as well. What are the challenges that we have to expand access to diagnosis? Brazil is a huge country. It's the size of a continent. So we do have a large diversity in the different regions. In the North region, we have many remote areas that are difficult to access. And in São Paulo, that has a complete different set of barriers. But expanding diagnosis in these remote areas is a challenge to be surpassed. We need to expand access to the key and priority population groups, because the challenge might not be geographic, it can be social, and that has an impact on the key population. We need to reduce the response time to users. They need to get an answer when they are in the health service center. And we need to allow for testing to happen in specific contexts, so we make sure everyone has access to it. And technology exists for that. Technology has presented us different options and different evolutions so we can overcome those challenges. Today we have point-of-care testing, which is conducted in the same place where patients are being seen by their health professionals. We have a near point-of-care testing. In this case, I need some sort of lab infrastructure, but it's a minimum infrastructure. And it is a device that is used under demand and that allows me to give an immediate response to patients. And I have laboratory testing. And in this case, I'm talking about locations that can work on a high volume, so we can centralize a large number of samples to conduct these large-scale testings. The challenge here is how I can fit all three options and have them working together as a network so I can provide a better service to the population. Next one, please. If we could go back one, please. And this is just a quick example of the different types of technology that are available today in Brazil. So for point-of-care tests, we have the immunochromatography tests. For near point-of-care tests, we have what we call rapid molecular biology technology. So they use cartridges. And we have automated molecular biology, which is present in large labs. So there are many options in this technology menu to choose from, with the goal of providing the best treatment for patients. So I have laboratory assays and rapid nucleic acids tests, including immunochromatography tests. These are different options with specific applications. And many times we wonder, regardless of anything else, we have this trend. We often try to rank these tests. And if there's one thing that Brazil has taught us, the Brazilian experience has taught us, is that there is no best test. It depends on the population, it depends on the goal you're trying to reach. I always need to evaluate the risks and the benefits before I implement a diagnosis technology. What are my risks? I can have a false positive or a false negative. What is the gain in using these tests? I have access, I have an individual benefit and a collective benefit. There will never be an ideal test, but I need to balance the risks and the benefits, and I need to use the tests in order to minimize the risk portion of this equation. So I need to think about who am I trying to reach with these technologies. So today, regarding the different actions that we take in our department, we try to create a network structure that is inspired in a pyramid shape. I have different levels of complexity that go from the level 0, which is the minimum level of complexity, up until a level 4, in which I'm using high-tech technology in reference labs that have a specific role to play in this network. But this division in complexity levels allow me to create different strategy for tests. I can have tests that is based on traditional health services and do other testing strategies that can reach these community environments, especially for the key population groups, and the possibility of testing through peers and partners, like the strategies that we use to distribute self-tests in Brazil. It is very important regarding the different actions that the Ministry of Health implement for us to think that diagnosis need to be kind of safely conducted, both for the patient as well as for the health professional conducting the tests. So for that, the Ministry of Health works with strategic partnership and different actions to ensure the quality of the results, especially when talking about these rapid tests that are being used by people who don't have a background in health. Next one, please.
E aí, além dessas, de todo...
So besides, José, we have lost you. José is having a problem with his internet connection. So let's go back to the main room and let's see if he can figure that out. I'm sure, I think he's having a connection problem. So we are a little bit behind schedule. But I will make a comment. When we saw the Cassiano presentations with COVID data, who were tested, their different age groups, the symptoms, and when we saw José's presentation now, which was also a presentation filled with data, with more than 30 years of HIV program, we are already talking about population groups and key population groups. So when we saw in Cassiano's data saying that 11% of people that went to drugstores to be tested were elderly people, but this was the age group that tested positive the most, perhaps we can establish this connection of who should be testing for COVID. This is why it's so important to have a public health program and a health surveillance in times of pandemics and during epidemics. Is Cassiano with us? So I'm going to ask Dr. Segundo to make a comment on the discussion we just had. We talked about the importance of fast tests in the drugstore, in the work environment, in basic healthcare. So how do you see that, Dr. Segundo, the use of rapid tests in this environment and how you monitor and validated that?
Algo muy importante, ¿no? El tema de atención primaria de salud.
So we've seen something very important. We've seen the strengthening of the use of tests in several presentations and the authorized tests in countries, different countries, even more complex texts. But the landmark of this pandemic was really the scale. The theme that you proposed and the use of several drugstores available in the country, pharmacies, to provide, more than 3,000 tests to the population. This was sort of a relief for the public healthcare system, because these people did not have to get to their hospitals or health clinics to get a test. And we've also seen that the percentage of positive cases with the rapid tests was low. And so that allowed for voluntary isolation and quarantine. So this is a very important approach. We work with the clinical evaluation in hospitals, and the next stages have to be scaled up so that we can bring those rapid tests to the community. Our team is working on an antigen test right now in a community center. We are actually closer to the more vulnerable population. So this approach is very important, not only to fight this pandemic, but future ones. We've seen what the Ministry of Health is doing regarding the 19-90-90 approach. So we have to bring medication to the population who is in need, or the example of providing medication to the people living with HIV. So if someone with HIV is a little more at risk of having severe COVID, so that it's important to make sure that they have medication available. Thank you, Dr. Segundo. Is Jose back? Jose, would you like to make a final remark? I would like to thank Elliot and everyone else for staying with us. So I would like to invite Jose now to say his final remarks, talking a little bit about the importance of diagnostics, because throughout the years we've seen new technologies being implemented, and we have to include that in the pandemic discussion. Jose, over to you. Thank you, Ana Flávia. My connection is not working really well, so I would like to, just leave you a message, which is, with innovation, with technology evolution, we are able to implement innovative actions. We need that. We have to innovate, and we have to have courage.
because back there, when we decided that we could do rapid tests, not everyone believed in it. So we have to innovate, and we have always to think about that. And when we talk specifically about the HIV epidemic, we have to show that this young population is getting infected, so we have to keep on innovating regarding the services provided by the Ministry of Health. We have to keep on offering diagnostics. We have to think that we do not have a lot of information regarding the incidence of HIV. We see that there's an important population, a part of the population that we're diagnosing later on. And so one thing that we really need to work on is the detection window. Tests with shorter detection windows will be very important to continue on fighting so that we reach the 95%, because that's what we have to think. The closer we are of the total amount of people living with HIV, the better it will be, and we need better tests. Thank you so much. Thank you, Jose. Pablo, would you like to make any final remarks regarding the use of tests in primary healthcare? You mentioned the importance of updating policies. So are you there? Do you want to say final remarks? Yes, good evening, everyone. I believe that the use of technology at the point of care is really the way to go. We've seen that. There are several studies demonstrating that it will help to control diseases, especially when we talk about diabetes, hypertension, and we're also talking about hypothyroidism. So what we need to advance now is in terms of legislation. We have to have a legal basis for that and really shift the paradigm regarding pharmacists and biomedics that have this argument that say that we cannot advance in terms of technology. In the United States, for example, there are 136 parameters available at points of care. So why not use them? We have to think about the quality of life of patients. We cannot clinch on these issues. We have to advance and always putting in first place the quality of life of people, so people do not, they cannot be in line for a hemodialysis because they cannot use a technology to control diabetes or hypertension just because regulation does not allow it. On the other hand, we also have to pay attention to quality. I mentioned that in my presentation. We do not choose any piece of equipment. We are thinking of devices that have external evaluation, and besides relying on external evaluations, we rely on our team to evaluate and guarantee the quality of the results of those tests. That is also essential. So those who benefit from rapid tests, the tests during appointments are the patients, and we have to think about them. Thank you so much. Dr. Cesar, would you like to say a few remarks regarding the use of tests at the point of care? Please go on, you have the floor. Yes, thank you so much. Thanks again for having me. So definitely the pandemic has brought us learning opportunities. So the test that we have today, just like Jose Alonso was talking about disruptive technologies,
and Pablo Maciel that was talking about technologies as well. This is something that we are able to use to reach diagnosis to other people, and we have to think about technology and information systems, and sometimes it's a mistake to see that from a laboratory point of view only. Sometimes taking quick measures and responses during the pandemic, I mean, it was lucky that we did not have cases in the workplace, especially because of the use of these tests before sending them to workplaces. So thank you so much again for having me. I would like to invite Elliot to say his final remarks regarding the equality of tests now. Thank you very much.
Yes,
the floor is yours.
Thank you very much. Just three things that I jotted down, not necessarily related to quality. Quality is essential, of course, but at the same time, access is also essential. And anything that can be done to increase access is critical. New technology is wonderful, but if it can't be used by the people who need it, then it doesn't have a lot of value. The second thing is I think we can learn from the pandemic. We have opportunities here on how to bring forward new tests quickly. We should concentrate on learning lessons from what we are experiencing right now. And the last thing is I would advocate for regulations to not only consider risk, but also to consider benefit. It's important that a number of speakers have talked about that today. That if the benefit outweighs the risk, then it would be that would be a good opportunity to have the regulations keep that in mind. So thank you very much.
Obrigada a todos os participantes por terem continuado aí conosco.
Thank you very much to all the participants for staying with us. We will be back tomorrow at 9 a.m. Brazilian time with more interesting panels. We will talk about self-testing. We will have the experience of new technologies being incorporated in the Brazilian healthcare system so that other technologies are incorporated. So thank you very much again. Thank you, Dr. Segundo, who is here on the stage with us, and to everyone watching us. Thank you so much. Have a good evening. Bye-bye.